under the able leadership of Dr. Sneha Bihar from Yavatmal. We are talking about latest advances in the prediction and management of hypertensive disorders of pregnancy in the next 2 hours. And I welcome Dr. Sneha to please introduce us to this webinar. Can I have Madam's CV, please? I think I'll just read. Yeah. Dr. Sneha Bihar needs no introduction. She has headed many committees of FOXI in the capacity of chairperson. She has been a leader in AMOX and CEPOC, been awarded. Welcome, ma'am. And I kindly request you to start the inauguration.
Thank you so much. I think Sahiti will do the honor first for inauguration. And then.
Sahiti, are you there?
Yeah. A very good evening, respected Dr. Rajendra Singh Pardesi, President of AMOX, Madam Sujata Darvidar, Secretary of AMOX, all the dignitaries here, especially chief guest for today's program, Dr. Nandita Palshetkar, Madam, and Dr. Rishikesh Pai has conveyed his best wishes considering the protocols for elections. Sir has not joined this program. And of course, the guest of honor, Dr. Ashwat Kumar and Madam Sunita Tandulwadkar. A very good evening to all the president and secretaries of the MP societies. My dear friend, Dr. Monica, who has, designed and executed this program. I welcome all of you here for this program on hypertensive disorders of pregnancy. I just share with you all that, because of this hypertension, hemorrhage and sepsis, these are the 3 major causes of maternal mortality, which are direct and preventable. Amongst Medical Disorders Committee is working very hard for in awareness and also for the screening and early detection of these disorders. Thanks to Dr. Rajendra Singh Pardesi, who has given me this opportunity. And with this, I welcome respected Dr. Rajendra Singh Pardesi for his pearls of wisdom. And all of you know sir as AMOX president, and sir has been a very humble human being, past vice president of FOXI, and of course the committee chairperson of Food and Drug Medical Surgical Equipment Committee. Sir, over to you for your blessings and your precious words, sir.
Good afternoon, everybody. Welcome you all for this AMOX webinar with MP societies. Respected chief guest, Dr. Nandita Pai, Dr. Rishikesh Pai, Nandita Palshetkar, Dr. Rishikesh Pai, guest of honor, Dr. Sunita Tandulwadkar, Dr. Ashwat Kumar, Dr. Lakshmi Srikhande, Dr. Ashok Kumar, Dr. Sujata Darvi. So I am feeling proud and honored to be a part of this webinar with Bhopal. So Bhopal is very close to me, and Bhopal has helped me a lot even in 2017. So first I wish to congratulate Bhopal and societies, MP societies, for joining hands with AMOX for this webinar on hypertensive disorders of pregnancy, and which is still a major cause of maternal mortality in India. I wish to congratulate Dr. Sneha Bihar for organizing such an academic and practical webinar. With the speakers, chairpersons, panelists, I think this is going to be a great event. I wish every success to Dr. Sunita Tandulwadkar for her future endeavor in FOXI as president of FOXI, and also to Dr. Sneha Bihar as vice president of FOXI in future India's now coming elections. I wish to express thanks to Dr. Nandita Palshetkar. She is now figure representative. wish her in Figo as President Figo to to gracing this webinar of AMOGs. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir.
Thank you so much, sir, for your blessings and, of course, the pearls of wisdom. I'm sorry, Dr. Sujata Darvish is busy in Foxy office doing some work and she's unable to join from there. She just conveyed her best wishes. And now I request Dr. Monica Singh to take over for further proceedings.
I think we need not waste any time because Nandita Palshetkar ma'am is known not only in India but all over the world. She is the absolute symbol of Foxy and Isar. Madam, we would like to have a few words from you, blessings from you.
Thank you, Monica. Thank you. I think it's always a pleasure to be introduced by Monica because she makes you feel as if on top of the world. So thank you, Monica. Sorry, I'm on my mobile because I couldn't get the connection on my laptop. But it's such a pleasure to be here. I think Maharashtra, headed by such a dynamic personality, Rajendra Singh Pardesi. And, when I worked with him, he is such a sincere and a fantastic human being. I'm happy that he is at the helm of affairs of Maharashtra. And all my friends from MP, coming together of these two associations is amazing. So I'm happy to see all my friends from MP over here. So great to see you there. And I think Sunita and Sneha, I know you all are both fighting elections. Sunita and Sneha, both of you all have been working so hard, have been traveling all over the country. I think the hard work is going to pay off. All the best. And you really deserve all the accolades, all the love, all the affection that you're getting. I think Foxy is a very vibrant association. See, today all of us are there. And I think the love and affection that we have for each other is courtesy Foxy. Otherwise, where will I meet Rachna? She's sitting there in Indore. I'm sitting here. Monica is in Bhopal. Kahan se hum milenge?
Madam, Rachna ma'am is in Bhopal now.
Yeah, Rachna is now in Bhopal, yes. Sunita, and me at least, we are in, I'm born in Pune, so I know Sunita is there, right there. But otherwise, it becomes very, very difficult. So I think Foxy has the fellowship which actually binds us. And it's a very, very vibrant association, which we really, and believe me, it's a very, very powerful post, the president of Foxy. It gives you so much. And today it's a brand value. It's created. Foxy presidency is a very important post. And I think one should really think very hard when you're selecting a candidate, when you're selecting your president, because the person that you put there really has a lot of, a lot of responsibility, a lot of work to do. It requires, you can see Dr. Pai now. He's traveling so much. Right now he's in the plane. That's why he couldn't come stay. He's traveling for his yatra to the south. And it's amazing lot of work. You are in all the government policies, you are formulating women's health, you are, of course, on the academic front, you're doing GCPRs for women's health. There's so much to do. And I'm really happy to see such dynamic people coming forward, to lead our organization. So I am wishing you all the best. I know we are very excited that only today is what? The 2nd of August, right? So only 8 days left and we'll have the results soon and we shall all celebrate. So all the best. And I'm glad medical disorders of pregnancy is something that is, something which we are really working on, even at the FIGO level, where I am the lead convener of the PPH Ampli, where it's one of the leading cause of maternal mortality. And I'm glad, Sneha, that you've taken up PPH as one of the, hypertensive disorders, because it's preventable and so many new things have come. So all the best. I won't take any more time. Hi, Randhir. Good to see you.
Yes, ma'am.
It's always a pleasure to see you. And I have such happy memories of my time in Bhopal and in Indore during the AICOG and during the ESAR. So all the best, and really happy to see Amog's Jhanda flying very high.
Yes, ma'am. Yes, ma'am.
So absolutely, and all the best, Sunita, Sneha. Looking forward to seeing you all in the national scene.
Thank you.
Okay.
Thank you so much, Nandita ma'am.
Thank you, Nandita. Love
Your
you.
words,
God
your words are
bless you.
spoken so much from the heart that they touch every soul. And now I invite our guest of honor.
ये बंद
It's
करके जा सकते हैं.
my extreme privilege to invite Dr. Sunita Tendulkar as our guest of honor. Madam needs no introduction because she has built up an image in India that a powerful gynecologist, endoscopist, infertility specialist, somebody who has brought stem cells into the reach of our gynec domains. And people are now encouraged to go into this field just because of her. She's pursuing her campaign with passion and determination. And I was really touched about the story of Madam's mom getting recovered from her renal condition with the help of stem cells. Welcome you, ma'am. Please bless us with your words of wisdom.
Thank you. Thank you so much. It feels, you know what, last 2 days I'm working for election campaign. When I see the familiar faces, the other faces, it feels so great and so nice, a beautiful break in your work. And Amog's doing huge work. This is a fantastic idea to tie up with each society, connect Amog's with every society. Sneha, fantastic work done. Dr. Rajendra Singh Pardesi, you are giving the free hand to your all chairperson. And that's why today Dr. Rajendra Singh Pardesi is in every society. Morning maybe with the hypertensive disorder, evening maybe with medical legal. So you are reaching to each and every society and you are making Maharashtra state reach with it. It's a fantastic. When it comes to Amog's, the only president of Amog's who was Dr. Nandita Palsetkar, I still remember we used to joke, Foxy presidency, Amog's presidency, IGP presidency, ISAR presidency, probably the only lady from Maharashtra who has done this. And that's because people love her. That is the only way I can say that sometimes. Today, Nandita never know I speak like this, but today I know her family background and how humble this girl can be. Everyone feels she is the best friend for themselves, and that's because of her nature. I think she has taken this gene from her father, who knew how to win the heart, and she does the same. Monica, you, Randir, my besties, when it comes to Bhopal, the beautiful city of Lake, presided by the past president like Dr. Anjali Madam and Nalini Mishra ji, and so many vibrant people of Bhopal. So Bhopal becomes vibrant because of you all. City of Bhopal with the legs, with the academics, with everything, and then the Kavalis. The way Bhopal celebrate the evenings are so different. So आपकी चाय भी अलग एटमॉस्फेयर में होती है, आपकी इवनिंग टी भी अलग एटमॉस्फेयर में होती है, और आपकी शाम भी बहुत अलग एटमॉस्फेयर में गुजरती है. You are the people who know how to live the life, how to combine your academics, your practice, and your family time with the personal enjoyment. Rachna, you have the flooded with the popular genes of the country, who never exhaust. I don't know which path you have to follow, but that is a very tough path, Rachna. I know you are conquering many feathers, but the cap which you are holding is very heavy. We see all Miraji at this age, receiving every alternate day different award. I said, oh my God, by her age, we will be retired. And look at this lady, iron lady, I should call her. So I'm today given me you all to be with you all. Believe me, even today, the Pune's atmosphere is beautiful. Beautiful rains going on, no sun, and we will be also enjoying aap logon ki tarah chai. So we'll enjoy all together. I wish all the best. Sneha, beautiful subject, beautiful topic, and great efforts. Thank you for making me part of this webinar and giving me an opportunity to be with you all. Thank you.
Thank you,
Thank you
ma'am.
so much,
you
madam,
so
and all
much.
the very best to you as well. Thank you so
All the
much.
best. All the best, ma'am.
Bhopal Society has given me huge love when I came. I can't forget that. It touched my every heart. So I'm really grateful to each and every one of you for your blessings. Thank you.
Thank you so much,
Thank you,
ma'am.
ma'am.
Ma'am, Dr. Ashwath has joined. Yes. I welcome our guest of honor, Dr. Ashwath Kumar, to this webinar. We know him as a great laparoscopy surgeon, and he is fellow of Gynec Oncology, GCRI, professor of Department of Gynecology in the Jubilee Mission Medical College, Thrissur, Kerala. He is well known for the brilliant quizzes he conducts. He's been the vice president of FOXI in 2019 and past vice president KFOG. Welcome, Dr. Ashwath Kumar. Is sir there?
I don't see him joined in the panel. So
Okay, ma'am. So
yeah,
I
so
think
I think
we'll proceed with the session one.
yeah,
With
we
your
can have
permission.
him whenever he joins. We can go ahead with the academic session. So once again, I just take this opportunity to welcome and of course thank for your gracious presence and your precious words, Dr. Rajendra Singh Pardesi, Madam Sujata Darvi, Dr. Lakshmi Shikhande, and Dr. Ashok Kumar, and of course, chief guest for today's program, Dr. Rishikesh Pai, Dr. Nandita Parshidkar, Madam, and Madam Sunita Tandurwadkar and Ashwath. I welcome and thank all the faculties for today, Dr. Rekha Wadhwani, Dr. Anjali Kanere, and of course, the many panelists and the chairpersons for today's program. I welcome all of you. Dr. Shruti Madhavi, welcome. And with this, I think, Monica, I hand over to you for the academic session. Thank you so much, everybody.
Thank you so much. The webinar today consists of 2 talks of 20 minutes each. The first talk is on prediction and prediction of preeclampsia and the hypertensive disorders of pregnancy and how it has changed in the last decade to make it more effective and more formidable in the prevention of complications. And the second talk by Dr. Anjali Kanhare is on management. Then we have a good panel on clinical case scenarios. And I request Sahiti from SHIELD to please introduce the chairpersons for the first session.
Thank you, ma'am. Let me introduce the first chairperson, Dr. Rachna Dubey, ma'am. Ma'am is currently the Director of Health Bureau, Madhya Pradesh, and in charge of Health and Wellness Center and Cancer Cervix Prevention. Ma'am is the first Indian to select for Preventive Health and Management course at Harvard School of Public Health, Boston. Ma'am has many accolades to her credit. And second chairperson is Dr. Randhir Singh. Sir is currently Sir has been organizing secretary of ISAR in 2016 Indore, organizing secretary of ISAR Embryology 2018 Bhopal, organizing chairperson of 27th annual ISAR 2023 Bhopal. Sir has many awards to his credit, awarded Best Oral Paper in IFS and Best Poster Award and Best Oral Presentation in IFFS, and more than 100 original studies and posters in ASRM, IFS, ISAR, Aspire, IFFS since 2008. I welcome both the chairpersons.
Thank you. Thank you.
And I request any of the chairperson to introduce the speaker.
Can I have the slide of the speaker? So I would like to introduce my very dear friend, Monica. She is a wonderful person and with so much of, I can see a huge list of the awards and achievements which she has achieved. Just to enumerate a few,
Madam, it's okay. I think because
she has got 10 gold medals in MBBS. She's a Women's Achiever Award by People's Group Bhopal very recently. She has got an Entrepreneurship Award, and then she has got Best Paper in Clinical ART, and the list is huge, Monica. But we all want to hear from you. So welcome, Monica, to this prevention of hypertension talk.
Thank you, Chairperson, Madam. And before I begin my talk, I would like to give a disclaimer. I'm sharing my screen, Sahiti.
Yes, yes, you can do that.
Yeah. I hope everybody can see the screen.
Yes.
Okay. A disclaimer that this session was to be taken by Professor Rekha Wadhwani, a very dear senior, who is heading the unit in Gandhi Medical College, Bhopal, and is a keen academician. But Madam was busy. We had an unfortunate incident in our medical college 2 days back, and there are some political and police issues. So Madam is dealing with that. I hope they settle down everything. And I hope our future Foxy presidents can bring down the stress levels of postgraduates all over the medical colleges in India in their tenure. Speaking about prediction and prevention of hypertensive disorders of pregnancy, we know why we need to do something. We need to do something because mothers are at risk and infants are at risk. There are about 10 million women around the world who develop preeclampsia every year, and there are 76,000 deaths from preeclampsia every year globally. Every 7 minutes, there is one woman who's losing her life due to this preventable condition. Now, why is this disorder important? Because it is affecting the infant mortality also enormously. Almost 5 lakh babies die from preeclampsia and other hypertensive disorders annually. It contributes to almost 25 lakhs preterm births also every year. So this mortality which we see from preeclampsia and HDP is just the tip of the iceberg, because what lies beneath is 9/10 of the iceberg, which is near miss morbidity. For every maternal death, there are 50 to 100 women who experience near miss significant morbidity, resulting in significant load on a health care management. Preeclampsia is also a window to future cardiovascular disease. We all know it's a multi-system disorder. So with pathophysiological changes which are secondary to reduced organ perfusion in almost all the parts of the body. The etiology is all jumbled up. So there's a two-stage theory. Either it's a maternal endothelial dysfunction which starts it, or it originates in the placenta. We don't know. But the pathophysiology definitely deals with this Venn diagram where immunologic, genetic, and pro-inflammatory mediators act together to cause faulty placentation, inadequate trophoblastic invasion by the spiral arterioles, leading to reduced uteroplacental perfusion. Now, this endothelial dysfunction could be the primary factor, or it could be reduced uteroplacental perfusion, but definitely it leads to a lot of inflammatory processes in the body due to oxidative stress, leading to capillary leaks, vasospasm, and coagulative disorders. The capillary leaks are the thing which cause the cutaneous edema, pulmonary edema, proteinuria, headache, blurring, and all that. Vasospasm leads to hypertension, oliguria, abruption, and seizures. And coagulative defects are what manifest as thrombocytopenia, hemorrhage, and DIC. These are the multi-system changes which occur in preeclampsia. It's a beautiful slide which is telling us the cardiac effect, the effects on the brain, on the lungs, the kidneys, the liver, and ultimately the fetus, which suffers from FGR, preterm delivery, and may die due to abruption of the placenta. So HDP is a big enigma. We do not know the cause, we only know the consequences. What we know, however, is very little. There is something called spiral arterial remodeling. We know this gun is fully loaded, but we do not know what actually pulls the trigger. So why do we need to predict preeclampsia? There is this story about 2 screening tests. The whole world is talking about Down syndrome. Down syndrome is a prevalence of 1 in 900. It affects only the fetus. The intervention nowadays is not termination. You can continue the pregnancy. Some patients terminate. But preeclampsia, on the other hand, which is being ignored, has a prevalence of 1 in 20. This is affecting both the fetus and the mother. The beauty about the prevention of preeclampsia is there's a prophylactic drug. So I think all the government machinery should work towards preeclampsia and its prevention. What exactly do we want to predict? We want to predict a score. This prediction of preeclampsia, the risk scoring, was given by NICE guidelines in 2010. And when I read this, the ACOG guidelines of 2018 are not very different. Even in 8 years, we have the same high risk factors and the moderate risk factors. High risk factors we know are previous preeclampsia, chronic renal disease, chronic hypertension, diabetes mellitus type 1 or type 2, and autoimmune disorders. The moderate risk factors have changed in the last 8 years. Now they are talking about first pregnancy and age more than or equal to 35 years, BMI more than or equal to 30, inter-pregnancy interval more than 10 years, and a family history. So prediction of preeclampsia at 11 to 13 weeks. This is a topic very close to my heart because I'm FMF certified and I do this routinely. So this is a very, very beautiful combined test which can bring up the detection rate of preeclampsia by as much as 90% if we do it routinely and religiously below the gestational age of 32 weeks. So this is a simple chart which comes on your ultrasound machine. And you have to just specify, sorry, I'll just take out my pointer. Yeah, so you just have to specify the pregnancy type, whether it's singleton or twins. We know that if it is a multiple gestation, especially being compounded by the ART we are doing nowadays, sometimes the risk of PIH is more than just double. It just, just multiplies. We have to know the exact dating. And for all juniors listening to this webinar, the best way to date is by CRL, especially CRL between the 45 to 84 millimeter. Of course, the examination date has to be certified. Then you should know the exact age of the woman. You should know height and weight because you have to take out the BMI. Racial origin because Southeast Asian races and Afro-Americans and Blacks are more prone to PIH. You should definitely know whether the mother is a smoker, whether her mother had the preeclampsia, what is the conception method, whether it's natural pregnancy or an ART pregnancy. Then you have to measure the mean arterial pressure. How to do it, I'll be telling you. You have to take the mean of the uterine artery pulsatility index, and you have to do your biochemistry. In biochemistry, preferably, you should be doing the PLGF, that is the placental growth factor, as well as PAP-A. There are newer biochemistry markers also, but they're available only in very high centers. Medical history you have to take for chronic hypertension, diabetes, and the autoimmune disorders. And you should know her previous obstetric history, especially if she had PIH in the previous pregnancy. So there's a very simple chart which comes on your machine, and this helps you to come to a calculator risk. So the first trimester multimodal screening for preeclampsia, you should first take the history from the woman, and then you have to measure the mean arterial pressure, the mean uterine artery PI, which are known as the biophysical markers, and the biochemical marker, which is being propagated, really promoted nowadays, and it is being taken as a part of combined test, is the placental growth factor. So triple test is nowadays gone because this is an old slide. What we do is the PE combined test. FIGO has also given its initiative on preeclampsia and given us a pragmatic guide for first trimester screening and prevention. Now, what FIGO says, the best practice guidelines or recommendations are, following the first trimester screening and assessment, the women who are identified at high risk should receive aspirin prophylaxis, commencing at 11 to 14 weeks of gestation, and the dose is specified as 150 milligram of the aspirin tablet to be taken every night at bedtime until either 36 weeks of gestation or till delivery, as soon as PE is diagnosed or preeclampsia is diagnosed. Low dose aspirin should not be prescribed to all pregnant women. You cannot make it a generalized blanket cover to all pregnant women. The reason I'll be telling you soon. So the triple test we are not doing, but definitely the combined test has a fantastic detection rate of 90% and 75% for the prediction of early and preterm preeclampsia. The false positivity rate is very low. So this is how the earlier you do the detection, the earlier you do the screening, the better is the detection rate. So in developing countries like ours and in third world population, this is something of a costly examination and diagnostic test. So a contingent screening pragmatic practice recommendation has been brought to a total population where they are subjected to first stage screening. First stage screening is a routine screening simply by maternal demography, history, and mean arterial pressure. You don't need any fancy gadgets for this. As soon as this first stage screening is screen positive, Then only you go to the second stage screening. Second stage screening consists of the measurement of PLGF, that is biochemistry, and the mean uterine artery PI. So only a subgroup of the population is tested. And those who are screened positive in second stage screening, they are then subjected to high risk antenatal care. So why should we measure mean arterial pressure? We've always been measuring systolic blood pressure and diastolic blood pressure. What is it about mean arterial pressure which makes it a better marker? This is because it's a better indicator of perfusion to the vital organs. And how do you measure it at 11 to 13 weeks? You can train your technician or your junior doctors or your staff. This is actually the mean arterial pressure is diastolic pressure plus pulse pressure divided by 3, or 1/3 of the pulse pressure. And pulse pressure, we know from our physiology, is systolic pressure minus diastolic pressure. So this is a simple formula which can be taught to our staff. And validated automated devices should be used. That's a good BP instrument. The woman should be rested for 5 to 10 minutes. Always support the arm at the level of the heart. You choose the proper cuff size and take the average of the two measurements in each arm. Needless to say, this woman should not have taken caffeine or anything in the preceding hour. No smoking, of course. She should not be unduly anxious, stressed. Bladder and bowel should be empty. No tight clothing. So you should, because blood pressure assessment is a very, very important test. We have to be very careful that we screen and take blood pressure and mean arterial pressure for a pregnant patients in a very conducive atmosphere. Now coming to Doppler, we always think as obstetricians, how should I do a Doppler? But I have in the audience Dr. Manisha Khare, myself, so many other people. We started learning this during COVID time and it just grew on us. Just have a good ultrasound machine. You ask the patient to just have a little bit of moderately full bladder, visualize the cervix, put your probe on the cervix, angulate a little on the right side or the left side. You'll see this beautiful uterine artery crossing over the iliac vessels. Just at the level of the crossing, you put your sample gate, and to cover the whole vessel, you have a proper angle of insonation. You should have a good, you get this waveform. And if the PSV or peak systolic velocity is more than 60 centimeter per second, you are doing good. And the mean of the two uterine artery PIs is taken as the indicator. So mean uterine artery PI more than the 95th percentile is considered as abnormal. But just a rule of the thumb is, at the time of NT scan, the mean uterine artery PI should not exceed 2.5. And at the time of anomaly scan, the mean uterine artery PI should not exceed 1.5. So these are the biomarkers which are nowadays being used. Placental growth factor is being done routinely. So placental growth factor has got an inverse relationship with the risk of preeclampsia. The lower this angiogenic factor, the higher is the risk of preeclampsia. And there are two other markers which are being used. They are the soluble endoglyn and SFLT. So this I've already told you how PLGF affects how is it related with preeclampsia? How do we use these monitoring? Another thing is the multiple of medians. We have to adjust all the values according of biomarkers according to MOMS, that is multiple of median. So whenever we have a set of values, suppose 10 or 11 or 13 values of biochemical tests, the middle value is known as the median. And the deviation of our test value on either side of the median is set to give us an indication of how far our test is deviating towards the positive side or the negative side. So the MOMS are the actual markers which are used to, draw inference from our biochemistry. Then there is an a priori risk. A priori risk is also a very popular term in fetal medicine people. This is actually the background risk, the background history of that particular woman. So what benefit will preeclampsia screening for my patient? You will say that we've been doing obstetrics for so many years. Why should we screen now all of a sudden? This is because of the ASPRE project. This project has been a landmark project for preeclampsia prevention. So you can see they screened nearly 27,000 women, high-risk group, agreeing to be randomized into two groups. Out of these 27,000 women, about 1,600 women were selected. They were found to be high risk. These women half of them were randomized to the aspirin group, 150 milligram per day, and the second group was assigned to a placebo. What they found was a substantial reduction in the substantial reduction in the incidence of preeclampsia when you started aspirin at less than 32 weeks. So the findings of ASPER trial was so dramatic that aspirin delays development of preeclampsia, that this was started being recommended all over. Moreover, admission to NICUs are reduced by almost 68% when you start aspirin at the right time. There's a role of calcium also. Those women who have got reduced low calcium intake or with calcium deficiency can be advised, according to WHO, nearly 1.5 to 2 gram of elemental calcium per day. But in general, we advise about 1,000 milligram of calcium, elemental calcium per day to pregnant women. There is a role we think L-arginine or nitric oxide donors may have, but we must say that there is no high quality evidence that administration of these nitric oxide donors can prevent preeclampsia. Moreover, antihypertensive drugs also do not reduce the frequency of preeclampsia, nor do they improve fetal or pregnancy outcome. But when there is moderate to severe hypertension, then definitely you can introduce antihypertensive drugs. Role of vitamin D supplements, it is everywhere nowadays. Vitamin D supplement may reduce the risk of preeclampsia. Folic acid is doubtful. Fish oil supplements definitely have shown a trend towards reduction in preeclampsia, and fish-rich diets also. But again, this evidence is low quality. Diet has no benefit results, these interventions, but definitely you have to give advice to this patient that she has to be taking her protein and energy supplements very nicely, very religiously. Obese women should have restriction of calories. Magnesium has got a role. Salt restriction is actually not required. So there's a beautiful, I think we are short of time, but otherwise this is such a beautiful slide, which I read yesterday, that what is the significance? Why should you not stop salt and calories for this mother? Because during pregnancy, the mother's blood volume increases 50 to 60%. Her liver is making albumin from the protein she eats. This albumin is similar to the egg white and pulls the fluid out of her tissues, helps to reduce the edema, helps to maintain her blood volume. If she doesn't eat enough calories, her protein gets burnt up for calories. We know the proteins are then burnt up as carbohydrates in the body and they are wasted. So this is being used to make albumin. This causes a drop in the blood volume. Now, when kidneys think that there's a drop in the blood volume, they think it's due to hemorrhage. So kidneys start producing an enzyme called renin, which makes blood vessels constrict, leading to high blood pressure. And mother, she thinks salt is bad for high blood pressure, starts restricting her salt intake. Now kidneys try to reabsorb as much fluid and salt as possible to increase the blood volume. But because there is lack in the blood of albumin and salt, this reabsorbed fluid leaks into the third compartment, causing edema, weight gain, and further increase in the blood pressure. And the result is what we get. So this is how you should explain to your patient the importance of these foods for preeclampsia. Of course, the green leafy cruciferous vegetables, winter vegetables. We have a lot of sweet potatoes in India. Sea vegetables we might not have, but we have got herbs. We've got electrolyte-rich fruits and berries in India. We have nuts and seeds, which might not be expensive, like coconut, quinoa. They are not expensive. Sesame seeds. We have legumes. We have dairy products, fish, those who can eat, and sprouts. So we have to give a lot of time to our patient about her dietary, pattern, what diet she follows. There is no strong evidence that exercise and physical activity can affect the risk of preeclampsia. So this is something of a score. We know it of it as HTB gestosis score and the dose of aspirin which has been advised. So this score, when the total score is more than or equal to 3, the woman should be marked at risk for preeclampsia. And this is a dynamic score. This involves all the existing and emerging risk factors in the pregnant women, with score 1, 2, 3 being allotted. And this is how it is scored. We have all these factors from that woman was born as a SGA fetus, to whether she has taken assisted reproductive treatment. So all these things are scored, and then we come to a gestosis score. We have to educate definitely our patient about the warning signs. Everybody knows. We have to, educate her about screening and management. This screening and management has to be really brought into our government programs and medical colleges, and good machines have to be provided to our postgraduates so that they start doing the mean uterine artery PI themselves. And they should know about the biochemistry. They should know about a priori risks and the adverse outcome of pregnancy. There is also a SFLT PLGF ratio more than or equal to 38, which can be taken as a valid factor. Then this placental growth factor can be triaged. If it is less than 12, this test is highly abnormal. If PLGF is between 12 to 100, this test is positive, abnormal. And if the PLGF is more than 100, then the test is negative and the woman is normal. So ophthalmic artery Doppler is also being done nowadays in many institutes. But the only thing I found about ophthalmic artery Doppler, though it's simple, accurate, even we can do it, the only thing is it is being performed after 34 to 35 weeks, when there is just like you have to terminate the pregnancy. So these are all the newer tests, glyphin levels and CART test. Congo Red is being, I heard from some consultants that Congo Red test is being given as, postgraduate thesis nowadays. And endoglyne levels, I don't know much about it. So why should I bother about screening at all? Why don't I give 75 milligram aspirin to all my patients? You'll think that. Now, this is very important. 3 reasons why aspirin should not be prescribed universally. Number 1, safety. Aspirin is not safe. It can cause upper GI symptoms, upper GI bleed, intracranial bleed. Second, compliance. Folic acid compliance is less than 50% in our population. How can you expect the patient to take aspirin compliantly? Those who comply with aspirin are likely to be the ones who don't need it. So targeted therapy is a must to ensure compliance. Moreover, what is NNT? It is numbers needed to treat. The prevalence of preterm preeclampsia is 3 in 1,000. So 997 women will be treated unnecessarily with aspirin to prevent 1 preterm preeclampsia. That is why we should not use as a blanket cover to aspirin to all patients. Multiple pregnancy, of course, can be adapted for first trimester combined screening, which can lead to detection of nearly all affected cases of PV, because we know multiple gestation is more prone to preeclampsia. But the problem is that it's got a high screen positive rate, more false positives, and we can use all the same markers for multiple gestation also. Now, what happens if we start aspirin after preeclampsia sets in? There is little or no value in women who already have developed preeclampsia, because at this late stage, aspirin does not prevent progression to more severe disease. In fact, it may exacerbate the bleeding in patients who have got thrombocytopenia in the background. So the take-home message is preeclampsia screening is here to stay, should be offered universally. FMF, that is Fetal Medicine Foundation, multimodal screening is the best option. The combined test should be offered wherever possible. In limited resource countries and third world countries, we can use the contingent screen model, that is maternal factor, demography, mapped for all, and PLGF and uterine artery PI added on for those at increased risk. Preeclampsia may never be totally predictable, but better prediction would help to focus on antenatal care more effectively. The placenta and preeclampsia, whether placenta is the villain or the victim. This is just hypothesized nowadays. The primary placental disorder, no clear evidence. Secondary placental dysfunction, there is emerging evidence. Cardiovascular dysfunction precedes preeclampsia by several weeks and months. There are abundant studies on this. Thank you all for your attention.
Thank you, Dr. Monica, for a wonderful presentation. It was excellent. And all those listening to this presentation, the very beautiful take-home message is that you must ensure that you must get biophysical markers and biochemical markers, especially mean arterial pressure has to be done in all the patients. And if it is found to be abnormal, you must start aspirin right from 11 to 14 weeks and continue up to 36 weeks. It has been so simplified and so beautifully explained. I think I don't have to enumerate. Add calcium wherever required in a very high dose. WHO recommends 2000, but invariably in government guidelines and as practitioners, we are giving 1000. Add fish liver oil, and L-arginine also has got a good impact. Thank you very much, Monica, for the beautiful presentation. Thank you very much.
Thank you so much, ma'am.
Thank you, Rachana ma'am, for giving time and advising of ourselves.
So you are such a vibrant person. Wherever you call anybody, everybody is always present there.
That's madam. आप लोगों का आशीर्वाद मैडम हमेशा चाहिए.
We want to Sneha,
Thank
ma'am.
you so much, Dr. Rachana.
Sneha, ma'am.
Wonderful presentation, Dr. Monica.
Madam,
Yes.
Madam,
Can
when
you
you
hear me? Can you all hear me?
Yes, ma'am. Yes, ma'am.
Yes.
Ma'am,
Yes,
one,
yes. So,
one little request from you. One little request from Sneha,
Yeah.
ma'am. Madam, when you become vice
Okay.
president, we really
Yes.
want Gopal to come up on the Foxy map. I have been.
Yes.
Yes, ma'am.
I promise you.
We want your blessings, ma'am. We want our Bhopal girls are so dynamic. Bhopal girls and one boy who's not a gynecologist.
Yeah.
so, madam,
Yes.
really
Monica,
want
my
your
dear,
blessings for Bhopal,
that
ma'am.
goes without saying. That goes without saying.
Thank you. Thank you.
Wonderful presentation by you, and thank you so much, Dr. Rachna, for accepting the invitation, and thank you so much for that wonderful compilation. Dr. Andit, pleasure meeting you as always. Thank you so much for being here. Thank you.
Dr. Sahiti, can you introduce chairpersons for the next session, please?
Yes, ma'am. So our next session topic is management of HTP, and our chairpersons are Dr. Pooja Patil. Ma'am is currently professor and HOD of LMMC Bhopal in Department of Obs-Gynae, and ma'am has teaching experience of 15 years, and ma'am has many publications in national and international journals, and ma'am has presented an oral paper in RCOG World Congress in 2021. I welcome you, ma'am. And our second chairperson is Dr. Manisha Jain. Ma'am is currently the treasurer of Bhopal Obs-Gynae Society, executive member of MP AGOI, life member of Foxy, IMS, AGOI, IAGE, and IMA, organizing committee of ISAR Bhopal 2023, and a professor of People's Medical College and Research Center, Bhopal, best paper awardee at MOGS OBS NCD Conference 2021, and ma'am has many publications in national and international journals and has teaching experience of 15 plus years. I welcome you, ma'am. And I hand over the session to chairpersons to introduce the next speaker.
Do we have the chairpersons here, or should I introduce?
No,
Yes, ma'am.
Dr. Manisha is there.
Yeah, very
Yeah.
good.
Yeah, just please.
Yeah. Thank you so much, Monica ma'am, and Ranjit sir for making me part of this CAB and webinar. It's my proud, I take extreme privilege and honor to introduce Anjali Kanhare ma'am, who happens to be my own mentor. Madam has been for the past president, and currently she is professor and head of the department of Chirayu Medical College, Bhopal. Madam has has many papers to her and awards to her credit. And more than that, she is a gem of person, a born leader, and very academic and multi-talented lady. Over to you, madam. Please welcome you, ma'am. Sure.
Thank you so much, Dr. Manisha.
Yeah.
I'll just take a minute for my screen share. Is it visible?
Yes, ma'am.
Okay, thank you so
Yes,
much,
Dr. Andini. Yes.
Thank you, Dr. Monica, for giving me this opportunity. It is wonderful to share the screen with so many stalwarts of Foxy. Yes, I understand that the election is not near the corner now, it is very much there. We all are pretty much in the Lake City, and we are like with the rains and everything, beautiful weather. We are actually in the middle of the rains with so many messages and flyers and n number of things. But believe me, this gives a very great opportunity to talk on something like latest advances in hypertensive disorders of pregnancy. Once again, it is a wonderful, I think it's a wonderful gesture for AMOX to be a part with Bhopal OBGYN Society. I really am thankful to Dr. Pardesi sir and Sneha madam for taking this initiative, because, okay, we always have a national and a regional societies of FOXY taking care of so many things, but coming closure state-wise also is going to make much of impact in knowing each other and walking towards one single goal together. That is one. Secondly, as Dr. Monica has really said, that we hope that the esteemed members, deserving members win. But yes, Dr. Sneha, this will be a sincere request from probably a teacher to take care of the postgraduate students also.
Yes.
Life is becoming very
all of you know, and I promise, Dr. Anjali,
Yes.
all of you know me. Once I commit, I fulfill the promise.
Yes,
So,
Dr.
thank you
Sneha,
so
it's a
much.
pleasure to have you as a friend also. So I'm using this platform because as you know that me and Monica, both our kids are doing a medical school. Day in and day out, it is becoming very difficult. There are a lot of issues like hypertensive disorders of pregnancy. We just don't know what the etiological factor is. But getting along as a teacher or as a student is making it difficult. So in n number of forums, I have been trying to tell that we need to have probably some kind of a counselor. I guess today it will be a platform for both. If we have a pregnancy-induced hypertension patient, if we have somebody talking to them all the time, telling them what to do and what not to do is going to make a lot of difference in the outcome. Similarly, if we have somebody who can a student get to talk to as a mentor, I'm definitely sure that it is going to change the scenario, and no other body than FOXY, which is the highest member body in India, can make an impact on this ground. So it's a sincere request to all the office bearers to take this into account. Let me start going ahead with the presentation. So since the topic was latest advances in hypertensive disorders of pregnancy, I thought of putting this picture when our Prime Minister gave the gift of metro to Pune yesterday. And why I have taken this picture? Because it is Pune, first. Second, it is MPOX. So it is a major society of MPOX. And the other reason for me to put this is the FOXY Justo's ICOG good clinical practice recommendations, which has a lot of inputs from Pune. So I could probably put this together, trying to mention to whoever is like there, maybe the PG students or the newcomers who are there, to realize that this kind of work FOXY is doing. They are putting a lot of good clinical practice recommendations, and this practice recommendation for hypertensive disorders in pregnancy came from mainly from city of Pune, and Dr. Sanjay Gupte, Dr. Gaurav Mandapurkar, Dr. Girja Vag, all of them were a part of this good clinical practice recommendation. And from there, that is where the justosis score, which Dr. Monica was trying to put, came into picture. Dr. Monica, you have had wonderful slides. My slides are not going to be that colorful. It is going to be a very simple presentation, but I hope the impact which I want to make is transmitted down the road. So we all are aware that hypertensive disorders complicate 8 to 10% of pregnancies. Preeclampsia complicates 3 to 9% of pregnancies in developed countries. Sitting in a tertiary care center, when I came across the emergency admissions, believe me, a lot of my patients, a lot of my maternal mortality patients are somewhere down the road suffering with hypertensive disorders of pregnancy. They come to us as postnatal cases mainly, but that is a sad part when everything else has been gone. All systems are coming to a closure. we just can't do anything much. So prevention, which Dr. Monica has so beautifully highlighted, needs to be impressed more and more. It is going to be significantly important to put this into picture in our day-to-day activity, that it doesn't really require to put patients for high biochemical markers. Even if we do small things, it is going to make a lot of difference. I would like to quote Professor Dr. Arul Kumaran: the only preventive measures which seem feasible are low dose aspirin, calcium, and magnesium sulfate. With this, though I'm nowhere close to Dr. Arul Kumaran, sir, I would like to add a very small note that the preventive intervention could be a BP record, a BP charting, and monitoring, and proper counseling. Believe me, if you tell a patient who is a known case of pregnancy-induced hypertension or diabetes, if they keep something like a diary, things are going to be much easier for the obstetrician to take care of them, to probably frame a medicine drug regime for them, the way the blood pressure is working. Probably it will be easier for them to highlight and put what investigations are needed at what time, and how those investigations are going to have implications on the outcome. All these things can be very well justified if this keeps something as simple as a BP record, which can be done by the patient herself, by her relatives, or maybe in a nearby any small clinic or a hospital which is close by. She doesn't have to go very far off for her BP charting records. Even with this, suppose if she is able to not reach to a tertiary center nowadays, so many facilities are available. She can probably visit the higher center once if she is a high-risk patient. She can send her all records on WhatsApp. Though NMC doesn't advocate this, but at least she can be in touch and can reach to a tertiary center as and when required. So how to manage these patients? The FOXY World Organization Justices recommend a systolic blood pressure more than or equal to 140 or diastolic blood pressure more than or equal to 90 warrants hypertensive therapy. The target range of blood pressure systolic should be equal to or more than 135, and diastolic blood pressure should be equal to 85 or less than 85 millimeter of mercury. The unfortunate part is we come across so many patients who are with this kind of blood pressure are started on the antihypertensive therapy, but then the blood pressure chartings are not there. So it is definitely advisable to keep a close look on what their blood pressure charts are. What are the maternal alerts when really we need to start with the management? We all are aware: persistent headache, blurring of vision, difficulty in breathing. These are all actually extreme signs. Second trimester vomiting, epigastric pain, feeling of ill-being. Sometimes even the patient's sixth sense, even if she's a preemie, she can come and tell you that I'm not feeling well, I'm putting on excessive weight, I'm unable to sleep. So those are the points when we definitely need to ponder and find out if something is wrong with her. With so much of stress going on in everybody's life, even a lot of our patients are working women now, and they are very prone to have these kind of symptoms. So we really need to know whether they are pathological or physiological, and we need to differentiate between the two. Uncontrolled hypertension, oliguria, breast tendon reflexes, altered consciousness, and sudden onset of massive edema. If the biochemistry also is haywire, these are definitely the maternal alerts when we need to be more careful. So what are the treatment objectives? The treatment objectives are to stabilize the hypertension and to prevent severe preeclampsia, to prevent the complications, to prevent eclampsia, to deliver a healthy baby in optimal time, and restoration of the health of the mother in puerperium. Believe me, I think we all focus too much on, I should not say too much, it is justified, but somewhere down the road, we forget restoration of the health of the mother in puerperium. And so many times we have postpartum mortalities with hypertensive disorders, and it is very painful if you come across a maternal death when the baby goes home alone. So as rightly said, Monica has categorically told us about the mean arterial pressure and all. So I'll not go into the highlights, but if postgraduate students are there, they need to realize when we try to tell them, I should not use the word scold them, but when we try to tell them that please do BP monitoring, they say, Madam sister ne le liya hai. Ya madam kali ko liya tha, aaj kyun lena hai? That is not on. One needs to realize that blood pressure is the most important clinical test in diagnostic hypertensive disorders of pregnancy. And even if you come across one patient who is on your rounds registered as hypertensive, that will decrease the maternal mortality by lot of numbers. So it has to be done with utmost care, and probably we need to emphasize this more and more. It is not the nursing agenda to do blood pressure monitoring. Yes, we can do screening, but postgraduate students also need to learn to take blood pressure and to be sincere in this. Which urine test? Dipstick is what is easily available now. Sometimes I tell my patient also to use dipstick test for urine test, so that if she is known hypertensive disorder of pregnancy, she can realize, call back and come for further management. Though the 24-hour urine collection is gold standard, but it is cumbersome, and gone are the days when me and Monica used to boil urine sample in emergency room in our alma mater. So definitely things are changing. This is something which the patient can do at her own space and can report back. Ultrasonography has a significant role in management. Dr. Monica has very well pointed out the role of ultrasound in first trimester. Besides that, if we come across a hypertensive disorder patient, we need to look for the liver for subcapsular hematoma, hepatomegaly, kidney for the signs of renal cause of hypertension, or other changes in renal parenchyma, ascites or pleural effusion, as these could be worsening signs of preeclampsia. When we come to ultrasonography for fetal surveillance and placental morphology, we all are aware that in third trimester, we do fetal biometry, amniotic fluid volume, uterine artery Doppler, and this could be one of the first one to diagnose preeclampsia. As rightly pointed out by Dr. Monica, Doppler are not very difficult, but yes, we need to get a hang of doing it. And I know that Dr. Monica and Dr. Manisha from Bhopal Society have really picked up it very well, and they are doing it on routine basis, and they are putting their beautiful videos on our WhatsApp group also. In confirmed preeclampsia or in known case of fetal growth restriction, evaluation of fetal growth, AFI, and uterine artery umbilical artery Dopplers will let you know how long you can proceed and when to go ahead with termination of pregnancy. More frequent ultrasound measurements and color Doppler studies are needed if there is high resistance or absent or reversed end-diastolic flow. Believe me, if you pick this up in time, and if you deliver this particular patient in a good center where you have good neonatology facilities, the outcome are really wonderful. I had a known, I should say relative, a first degree cousin of mine, in which there was a hypertensive disorder of pregnancy and there was absent end-diastolic flow. She was very preterm. I took her to a very good center, neonatology center, did a section over there. Her baby weight was just 600 grams, but the neonatology center did wonders. And I was trying to find out a video of her, but I could not get it today. Her grandmother is a singer, her mother is a singer, and this girl, just 3 years old, sings and plays tabla also. So you can do wonders if you are very close with your monitoring, and one needs to be very sure about that. Placental location, morphology, and any evidence of placental hemorrhage also should be documented. Dr. Monica has rightly told you about the aspirin, when to give, why to give, and what are the other benefits. But as rightly said, not all patients are to be given aspirin. Every patient, even if with a normal pregnancy in a medical college, we come across so many prescriptions where every patient is given either a progesterone support or aspirin without justification. The alarm is right now on antimicrobial resistance. Believe me, something like this can happen in our hormonal system and changes also, and probably we will start missing on these wonder drugs at a later time. Antihypertensive drugs, we can use labetalol, which is the first line drug. There are other drugs, but the first line of treatment of choice is labetalol. The oral dose of 200 or up till 1200 milligram per day can be divided into 2 or 3 doses depending on the individual condition. A word of caution here is don't start with the high dose at the first instant. One needs to know the physiology of blood pressure changes in first trimester, second trimester, and third trimester. And I always tell my colleagues to keep some dose in hand if the patient doesn't have control on her blood pressure. If you start with something at a very higher dose, thinking that, okay, our blood pressure badhna chalu ho gaya, so let's start with 200 or let's start with more than that. Then at third trimester, we have nothing in our hand to start or to put her up on. So we can titrate and modulate the drug as required. On the other hand, an intravenous bolus of 20 milligram labetalol is indicated in severe cases and could be followed with a double dose in 10 minutes time. So I was trying to tell you that labetalol is the first line drug. It is antihypertensive, which works as oral as well as IV and is combined both selective competitive alpha-1 adrenergic blocking and non-selective competitive beta-adrenergic blocker. It is a wonderful drug. Probably when we were doing our post-graduation, we grew up using methyl dopa, and when M-dopa was out of the market, probably there was a little bit of jitters to go ahead and start labetalol usage. But believe me, once you get into the newer system, you start adapting to the newer system. So labetalol is something which works in decreasing peripheral resistance, and it protects heart from reflex sympathetic drive, decreases blood pressure, and does good control of hypertension in hypertensive disorders of pregnancy. The next drug is nifedipine, which is safe, effective oral drug for lowering blood pressure. The advantages include relatively low cost when we talk about our Indian scenario and its wider acceptability. This medication functions as a calcium channel blocker, a rapid vasodilating effect, but is associated with few side effects like hypotension, headache, flushing. It can be started as 10 milligram dose and could be repeated later. The next drug is another wonderful drug, magnesium sulfate. Though it is not an antihypertensive, but it can be used in pregnant women, it is still considered safe as long as close surveillance is performed. It is useful for prevention of convulsions and associated with less morbidity and mortality rates. It is safest drug, recommended as first choice for eclampsia. You can use Pittard regime. Magnesium sulfate is to be continued 24 hours after delivery or last convulsions. We have had a couple of cases. I think Dr. Manisha was also a part of that particular case where we gave magnesium sulfate in late second trimester, and we did stop it. The patient did good, and we delivered the patient in third trimester. It was one of the case which was in initial days, and I found that very interesting. So even it can be used for such patients also. Serum magnesium monitoring is not required routinely. I'm not going to go into the detail of how magnesium sulfate is given. It is given, we all are aware that by Pritchard regime or Zuspan regime, and needs to be sure that we monitor the patient when we are putting the patient on magnesium sulfate. Nowadays, we are using magnesium sulfate as a neuroprotector also. So maybe things will change. We can get things which will be easily available and maybe more effective in eclampsia also. Me and Monica will again go back and realize that when we were doing our post-graduation, there used to be 4 or 5 cases in the month of August, all the time in eclampsia room. And the maternal death was almost more than 100%. One day you see the patient, admit the patient, next day you realize that the patient is no more there. So the scene is changing, and there is always a silver lining in the clouds. So we need to watch for that and move ahead with that. So when antihypertensive therapy is started, the aim of therapy should be have a good control of blood pressure. It can be used when the medical provider is aware that what should be the onset of action, the potential side effect, and one needs to realize in counseling the patient for the same. Nifedipine should not be given in sublingually. There is no role of ACE inhibitors and angiotensin receptors. Chronic hypertensive women already on these medications should be switched to safer antihypertensives. There is no role of atenolol, prazosin, Lasix in these kind of patients to manage hypertensive disorders of pregnancy. In case of severe preeclampsia, we can use labetalol. We have been using it routinely now and getting good results. So let us come and find out what is the timing of delivery, how to put the timing of delivery into picture. If a patient is just a case of gestational hypertension, she can be taken to term. If she is a mild preeclampsia, should be delivered at 37 weeks. A patient with severe preeclampsia should be delivered after 34 weeks if possible. Eclampsia should be delivered once stabilized within any time of gestation. Corticosteroids are to be given for fetal lung maturity. We always used to have a fight, blood pressure hai, steroid se badh jayega. No, the results of giving corticosteroids are again evidence-based. So don't hesitate in giving corticosteroids. We still in our peripheral center get tertiary center get patients from periphery who are not given corticosteroids, and then we have to wait and think that at least ek dose to push ho jaye. But if such a small intervention is done, things will be much different as the outcome is. Cesarean section can be done for obstetric indications. Preeclampsia without severe features, more than 37 weeks, delivered less than 37 weeks, go ahead with expectant management. Bed rest has no evidence base. It is no longer suggested. Serial maternal assessment, definitely yes. Fetal assessment, yes. And the patient should be on oral hypertensives. Severe preeclampsia, more than 34 weeks, definitely delivered. 33 to 34 weeks, steroid and delivered. 22 to 32 weeks, extensive counseling, antihypertensive, close surveillance, maternal fetal indication, in a good NICU setup, delivered. Less than 22 weeks, definitely the things are going to be very difficult and proper counseling of the patient is required. Indications for induction of labor, aggravation of any preeclamptic features, hypertensive persist in spite of medical treatment, acute fulminating preeclampsia, atypical presentation of preeclampsia, and tendency of preeclampsia, tendency of pregnancy to overrun the course as being there, needs induction of labor. When to do cesarean section, then urgent termination is required if cervix is unfavorable, severe preeclampsia, and associated complications, complicating factors like elderly priming, contracted pelvis, malpresentation, and derangements in her parameters are definitely indication for cesarean section. Though I came across this slide, which was very disheartening. The slide says nothing has changed. The first description of preeclampsia was done by Hippocrates almost 2 millennia. Since the description, the syndrome of preeclampsia and eclampsia has remained as a multi-system disorder. The diagnosis is based on a clinical picture and laboratory analysis. The therapy is only symptomatic, but giving birth still remains the only part of therapeutic treatment. We need to remember to lower the blood pressure promptly but slowly. We need to start with loading dose of magnesium sulfate. If there is no need of maintenance dose, we should curtail it. Expectant management should take care of the fetal lung maturity also. There could be various crises in preeclampsia as eclampsia, HELP syndrome, pulmonary edema, placental abruption, cerebral hemorrhage, cortical blindness, DIC, acute renal failure, which in our institute we are coming across postpartum also. Probably the patient is not given a lot of fluids or whatever things go wrong in management somewhere down the road. These patients require dialysis. They land up in multiple organ systemic dysfunction, and the maternal mortality is very high. So we need to be aware about these crises. Postnatal blood pressure management also should be one of the part of counseling. They just stop, especially this is seen in patients with chronic hypertension. They just stop taking medicine. They conceive thinking that miracle will happen this time. And then they again come back with superimposed preeclampsia, with intrauterine growth restriction, with placental abruption, and difficult to give them a healthy baby and a healthy mother without morbidity. As per the NICE guidelines, um, these guidelines tell you when to admit to the hospital, how to measure blood pressure, how many times to measure, what is the role of proteinuria. All these guidelines give us basically a viewpoint to organize our treatment protocol, taking into these guidelines into picture. Whatever best we can do for the patient, one needs to do that. So these are some studies in which they have shown that labetalol is the first line of treatment when we compare it with other drugs. I'll not go into the detail, but as postgraduate student could be there, one need to know why methyl dopa is not the drug of choice anymore. It takes longer than 24 hours to start with the action, needs to be taken multiple times. There could be chances of postural hypertension, common side effects could be there, hematological manifestations are there, and it gets accumulated and can cause renal failure. So this is not the drug of choice nowadays. Most updated ACOG guideline in 2018, the choice between expectant management and prompt delivery should be made based on gestational age, maternal condition, fetal well-being. Those with reassuring antenatal test, no signs of preterm labor, and no severe disease features make good candidates for expectant management until 37 weeks of gestation. This is another paper which I came across when I was reading about it, and it did mention Dr. Monica has taken good care of fluid and diet management and exercise. And when I was looking back, I think even Justos's management has the GCPR guidelines also says about the fluid and diet management and exercise. Exercise is definitely putting a role when transient hypoxia because of exercise can lead to compensatory proliferation of trophoblast. With this, even the oxidative pathway gets changed, and it has anti-inflammatory effect also. So definitely, if a patient is told to do some kind of exercise which are more aerobic, maybe there could be a change in scenario. And one needs to emphasize the reason of long-term follow-up, which is very, very essential. This is what is painful when you come across a death summary which says that septic shock with MODS, with PIH, with eclampsia, with HELP syndrome. These things are preventable if we are able to take care of these patients in right time. The future is, as rightly said, it has a lot of enigma, but the enigma of gestosis probably will finally get resolved by science of genomics and epigenetics. Thank you so much.
Thank you so much, ma'am, for such a wonderful and exhaustive talk. You summarized this vast topic in such a beautiful way, in such a small this thing. And very rightly, you pointed out upon the postpartum surveillance, which is very important. The pregnancy itself forms a very important window of opportunity to counsel this woman, not even just postpartum, but even the future risk of cardiovascular disease in these women. So these women have to be besides, and it's very saddening, definitely, that hypertension still continues to kill our mothers. We have been over very obstetric causes of death and other causes of maternal death, but hypertensive disorder still continues to kill our mothers, which is very saddening. And despite so much of advances, which Monica Madam stressed upon on how can we screen the women, we can predict, but still the management continues to be delivering the women and timely delivery. Thank you so much, ma'am, for enlightening with a wonderful talk. Thank you so much.
Thank you, Dr. Monica and Dr. Manisha. And
Thank you so much.
Thank you, Dr. Sneha. Wish you all the best from our society.
Thank you so much, Dr. Anjali, for that wonderful presentation. First of all, accepting our invitation and, of course, doing full justice to the subject. Thank Thank you
Thank you
so
so
much.
much.
And wonderful compilation by the chairpersons as well. Thank you so much. Over to you, Dr. Monica.
Thank you so much, ma'am. Thank you.
And if at all the chairpersons, if they have to make any comments.
Thank you so much, Dr. Anjali. Dr. Anjali Kanhare is heading a very premier Medical College of Bhopal, and I feel that you all senior obstetricians sitting in medical colleges are the real warriors. You are the real heroes. What you do, we are observing. We are observing very carefully, because whatever is being done in medical colleges has a reflection on society. The patients, the plum patients coming to us do not reflect the society. It is medical colleges which reflect. Your practices will affect all postgraduate studies. Your practices will affect the future of the country. So hats off to you, madam, for making the topic so wonderful to hear. And I was recalling all the days we saw eclampsia room, Excel charting, 4 बजे मैक्सेल लगाना, 2 बजे मैक्सेल लगाना. Some women had their arms tied, it was,
Yes, it was painful.
Very painful. Yeah, so we want the youngsters, Shruti sitting here, Manisha, Swati, Sushruta, you have to take forward obstetrics of India to a different level. You have to prevent maternal mortality. Thank you so much. And now, without further delay, we go to our much awaited panel discussion. And I have listened to Sneha ma'am moderating wonderful, wonderful panels when I was a part of her panels. And she's a very, very soft moderator. You'll never feel intimidated by her. So, madam, I welcome you to please moderate this panel on interesting case scenarios. Madam is standing for Vice President from the West Zone. She is a phenomenal leader, has received so many awards, and has done a lot of work in rural obstetrics. I was once moderating a panel with her in Pune about 13, 14 years back. And that time her obstetric practice was so heavy. So heavy means she used to start working at around 7 o'clock in the morning till night. I mean, Maharashtra and UP obstetric work is a different level. So, madam, your experience must be also phenomenal. Welcome you, ma'am, and please I introduce your panelists to us.
Dr. Monica, if you can introduce the panelists, that will be great. I'm just sending the link to Dr. Ashwath. He will be joining in 2 minutes.
Sure.
Yeah, by the time you can.
Yes, ma'am. So it's with extreme honor. I am honored to have Dr. Nalini Mishra with us. She is the Dean and Professor OBGY in Ellen Medical College and JK Super Speciality Hospital, Bhopal. Madam is known in India and worldwide for her crusade against PPH. The Chhattisgarh is an innovative low-cost uterine balloon tamponade device, and the Chhattisgarh drape is an innovative low-cost drape for estimating the blood loss at delivery. She has had so many innovations to her credit, low-cost concept to rationalize the transfusion of blood products in PPH. Madam, it's an absolute pleasure to have you on board with us.
Thank you, Monica.
And now it is with a lot of happiness I introduce our Nightingale of Bhopal, Dr. Manisha Khare. And she is such a sweet and soft-hearted person. It's an absolute pleasure. I've been knowing her since so many years. She is a wonderful person. She has been president of BOGS in 1920, senior vice president, speaker, chairpersons in so many CMEs, a very vibrant part of our menopause society, MP Obs-Gynae Society. She's been the vice president. She worked for a lot of years in Sultania Zanana Hospital with great obstetric appearance, great obstetric experience. At present, she is director and consultant of Manisha Hospital. Is very much interested in rural camps, adolescent health awareness. She has been a part of Beti Bachao, Beti Padhao Andolan cancer awareness. Welcome, Manisha, ma'am. Next, I would introduce our current president of obstetrics and gynecology of Bhopal from 23 to 25. She is a very keen academician and a person who speaks her mind. She knows when to say, what to say, and the correct thing she says. So I really respect Dr. Anita. She is my obstetrician also. So she has done post-graduation from Government Medical College, Jabalpur, and residency from GMC Bhopal when I was a postgraduate. At present, she is associate professor at Chirayu Medical College, Bhopal, and she has held many important posts in Bhopal Menopause Society, Bhopal OBGYN Society. She is trained in advanced gynecological laparoscopic surgeries and has got special interest in routine obstetrics, high-risk pregnancy, adolescent health, and cosmetic gynecology. Welcome, Dr. Anita Srivastava.
Thank you, Monica, for the nice introduction.
Welcome, Didi. And next I introduce our very sweet, she doesn't seem like professor to me, but she's a professor, Swati Sharma, very sweet girl from the Department of OBGYN, Mahavir Medical College. She is an alumnus from Jaipur, which is a very famous college. SMS Jaipur, my God, the ratings go so high. She has taken infertility training, ultrasound training, and ETHI skills course, FMS training, FMAS training, FCCS training, biomedical research, SWOG recognized. My God, is there something you don't do, Swati? I don't think so. Welcome, welcome to our panel. Next, I invite Dr. Preeti Verma, and she is an alumnus of GMC Bhopal and a postgraduate from NSCB Jabalpur. At present, she is Director Gynecology, Metro City Hospital, Bhopal, Associate Professor in Mahavir Institute of Medical Sciences, Bhopal, and she also served in GMC Bhopal. Welcome, Dr. Preeti. Nice knowing you through Swati. And we have a very artistic person now, Sushruta. She's the one who makes those fantastic posters, no? And
yes, ma'am. Thank you.
Yes, Sushruta, you are everywhere whenever there's a competition. So I welcome Sushruta, who is a postgraduate and FECOG from Bhopal, I think.
Yes, ma'am.
Yes. And at present, she is in associate professor in RKMC HRC with several publications and is a life member of prominent associations. Welcome, Sushruta.
Thank you, ma'am.
Shikha Gupta is another very dynamic gynecologist of Bhopal. She's a very favorite junior of mine, and we work together, we dance together. So she's very active in ISAR, Foxy, both. She has again been certified in USG. She's a life member of Foxy IMS IMA. She was in the organizing committee of ISAR Bhopal 2023, where she worked very hard. She has experience of over 10 years, has been awarded for excellent work in safe abortions. She has been awarded for achieving the contraceptive target by IPAS and is the medical director and chief of OBGY in Deep Shikha Hospital, Bhopal. Welcome, Shikha.
Yes, thank you so much, Dr. Monica. We have Dr. Aswath Kumar, the past vice president of Foxy, and who is the chairperson for this committee, and now the president of Kerala Federation of Obstetrics. I would invite Saiti, can you please stop sharing for a moment? Dr. Aswath has joined since long. We will have his precious words first, and then we will start our panel discussion. So we invite Dr. Aswath Kumar.
Hello.
Over to you, Dr. Aswath. Yes, please.
Hello, can you keep the phone? Just I'm in a meeting, Zoom meeting. Hello. Hello. Hello.
Yes, Aswath, we can hear you.
Sorry that. First of all, thank you for inviting me for this program. I am so happy to be a part of. First of all, sorry that I was late for this program, only because we are discussing hypertensive disorders in pregnancy. I was just doing cesarean for HELP syndrome. So something related to this only I was doing. It was just to start discussion. It was a grade Gravida 5 apply APLAS syndrome, previous 4 abortions and 1 hysterectomy for HELP syndrome last year, and the baby, the 24 weeks, did not get the baby. This time, the whole APLAS syndrome, she was on twice heparin BED with all, she was history of thrombosis, everything was there. We were closely monitoring. Patient started PIH from 24 weeks. She was on double drugs with Nicardia and labetalol. Patient is on labetalol and Nicardia. Closely, she developed a UGR. Then also we were closely, and the platelet count slowly started dropping. Finally, today morning, platelet count dropped to 80,000. Not only 80,000, her BP started raising, and the 32 weeks, your Doppler was showing absent end-diastolic flow. So just I had to, because we had to keep patient had taken food in the morning, so we waited till 6 hours. That is why I was doing a section for HELP syndrome. Baby is out 1 kg, 1.2 kg. Mother and baby are happy because they are 32 years without a kid actually. So that's why I was late. So it was something related to hypertensive disorders that I just.
Ashwath, can you please unmute yourself? I think you got
narrated story. Anyway, thank you so much for inviting me, and thank you AMOX, the president Paradesi sir, Nandita madam, and AMOX president AMOX Kiran sir, and Sneha Beer madam, and all the people, all the seniors who are there. I don't want to be in between your talks. So very important topic, hypertensive disorders. So we deal it every day, and every day everyone see at least one patient of a mild PIH, at least a gestational hypertension. So very nice discussion. I've been listening for some time only. I will be there for the rest of the discussion of the clinical scenarios. So all the best, Neha Boyer madam, for your vice presidentship. Thank you once again. Thank you all for inviting me for this program, and sorry once again for being late. Thank you.
Thank you so much, Dr. Ashwath, and thank you so much, a person who is so academic and so much working hard. You being here with us, it's a great pleasure, and thank you so much for your best wishes as well. Thank you so much, and over to you, Monica.
Yes.
Sorry for interrupting.
I really welcome Dr. Ashwath Kumar. I just talked to him in the afternoon and he could make it. We welcome you as a guest of honor, and we always look upon your abilities as a great academician and especially a great quiz master.
Thank you. Thank you, Monica.
We really enjoy listening to your quizzes. So can I have one more CV of Shruti Malvi, please? Yes. I welcome Dr. Shruti Malvi. She is the only person who is connected to Bhopal, but not at present in Bhopal, but she is very dynamic because she is not only the president, or she has been the founder secretary and president of Narmadapuram Obsgyne Society, which was previously called Hoshangabad. She has experience of more than 20 years, and she has done some pioneering work in daycare deliveries with national and international presentations and publications. She is also involved in a current community obstetric project of remote pregnancy and labor monitoring. She is a very active worker in the Pradhan Mantri Surakshit Matritva Yojana. She specializes in hospital management, and very interestingly, she's a writer. So she's written 2 great novels, The Final Conspiracy, Love Can Hurt, and Born Muslim in India, Boon or Pain. Welcome, Shruti.
Thank you, Rivi. Thank you very much. आपके मुंह से बहुत अच्छे लगे शब्द.
So, ma'am, we can start the panel now.
Yes, thank you so much once again, all the esteemed faculties for joining this program, and thank you, Monica, for introducing the panelists so well. Yes, so I hope my screen is visible, and I just put it on full screen, so hope it is visible. So I welcome all my panelists, Dr. Nalini Mishra, Dr. Manisha Khare, Dr. Anita Srivastav, Dr. Preeti Verma, Dr. Sushrita Srivastav, Dr. Shruti Malvi, and Dr. Shikha Gupta. So Friends, just in the beginning, actually, I wanted to say a few words about hypertension. That in spite of, having the so many of predictive factors for hypertensive disorders of pregnancy, including the maternal characteristics, and you have so many biophysical and biochemical predictors as well. In spite of all this, very well said by Madam Anjali Kanare, that the incidence of hypertensive disorders and the complications and mortality associated with it are still not on decline. So friends, women are dying not because of the disease we cannot treat, but because the societies have yet to make the decision that their lives are worth saving. And we obstetricians are the privileged one. If we, as a whole, can take a place that yes, we protect our women from the hypertensive disorders of pregnancy, of which majority of it we have understood by now, though the exact etiology, one single etiology is not identified. And with this, straightway, without much ado, we go to the clinical case scenarios and the discussion. So we start with Dr. Manisha, or any panelist can take up this. This is a case where you have 22-year-old primi gravida belonging to a low socioeconomic status. She has no medical comorbidity associated, and there's no family history which is significant. She is a registered case with uneventful course till now. Now at 32 weeks, when she comes to you for a routine checkup, her blood pressure reading is 140/90. How should we manage this patient? First of all, whether should we label her as hypertensive? What is your take on this?
Madam, she is hypertensive. 140/90 is the reading. Equal to or more than that is called hypertension. It can be a gestational hypertension, or it can be a pre-eclampsia.
So first, sorry to interrupt you. My first question is, should we label her as hypertensive right at this point of time, or you want to apply some criteria, or how would you like to go ahead?
Only one BP recording, we cannot say that she's hypertensive. We have to re-record her BP after 4 to 6 hours. And who has recorded the BP, that also we have to see. We have to measure it again in a right way. And then we can call her as hypertensive. It can be a gestational hypertension, and after investigation.
Coming to your right way again, what is the right way? Because this is a very, very important lesson we want to, we want to message our obstetrician as a community as such. What do you mean by right way? Whether it is immediately after coming to the clinic, or hurriedly rushing to the clinic, or how? What are the criteria you want to say that it is in a right way?
She should take rest at least for 5 minutes if she's climbed and come, or she's come walking. And then after 5 minutes, when she is relaxed, we should take the BP after keeping the hand at the level of her heart, resting, not either up or down. It should be at the level of the heart, resting on her arm on a table. And then the BP instrument, the cuff should be of appropriate size, medium size if she's a thin-built one, and if she's obese, then the cuff has to be tied midway between the arm and the shoulder joint, midway, and it should be sufficiently tight. And then we have to record the BP in a proper way.
Yes, very well said, Dr.
And arm, also the legs should not be crossed over each other. She should keep.
So perfect, very well said that, something what is called as the white coat hypertension. The moment she sees you, she gets raises her blood pressure. That also can be one reason. So you greet her, you relax her, and then maybe after 5 minutes you take her blood pressure, physically and mentally relax. She has to empty her bladder. She should not have any drugs specifically before coming to the clinic. May even it be even the painkiller, or even some eye drops which can also affect the level of blood pressure. If that is after 5 minutes, if that is the same, then meanwhile you send all her investigations, but you would like to confirm once again after 4 hours. So that is how, once you confirm it after 4 hours, and if the blood pressure comes above 140/90, you label her as hypertensive. Now coming to this, how would you manage this patient? Dr. Nalini,
Yeah.
madam, you can take up this.
One thing I want to add in taking the blood pressure is that with which instrument we are taking the blood pressure, because the aneroid sphygmomanometers are really notorious in wrong recording. So, and mercury sphygmomanometers are not available nowadays. So it has to be liquid crystal or other any BP instrument which is calibrated and which is validated for use in pregnancy. So that is one important thing. And secondly, the management now she's diagnosed as that she is having hypertensive disorder of pregnancy. Now, how to further manage depends upon whether she is having preeclampsia or not. So for that, we have to do her urine test and then certain other investigations, because only proteinuria will not suffice because even if the proteinuria is not there, but there is evidence of other end organ damage, may it be cerebral, pulmonary, or liver affected, or uteroplacental affection. So so many criteria have come, and we have to take care of all these things. And if she's pre-eclampsia, we have to manage her accordingly. If she is not pre-eclamptic, then at this BP, we can even send her home and ask her to come again.
Yes. So, madam, it's what the message we want to deliver here, that only the blood pressure of 140/90 is not a predictor of severity of the disease. So if at all she has some alarming symptoms, like severe headache, blurring of vision, upper abdominal pain, maybe even oliguria, and of course, if she has some alarming signs like, hyperreflexia, brisk reflexes, and epigastric tenderness, then we may label her as severe hypertensive in spite of her blood pressure being 140/90. Now, what investigations you want to send for this lady, and how do you, interpret it? What are the investigations, madam, you want to send?
Because see, if on the urine test, generally we go for dipstick, because it's not possible, not pragmatic to do a 24 hours. So there is a controversy whether it should be 1+ or 2+. The latest NICE guideline, April 23, it is saying 1+, and the ISSHP guidelines, they maintain that it has to be 2+. And then if the urine is concentrated, that may again come means significant.
So
even
apart from the urinary protein,
apart from that, so this message I want to really say that do not send all the investigations of like all the coagulation profile and all. First you send the CBC, and which must include,
madam, what all things you can interpret from CBC. That's a very good message.
Yes, hemoglobin, platelet count. So these are the two main things we have to see, and then the liver function test, and particularly the AST, ALT, and we have to do that. There is this full pair. So full pair
Any
test,
message you want to give regarding this
and urine creatinine also, ma'am. And then her ultrasound and a color Doppler in that. So these are some things that we should actually send immediately.
Very well discussed, madam. Yes, you have to send the complete blood count and the liver enzyme specifically, the renal function test, especially blood urea and creatinine levels. And of course, from CBC, you get the cell indices for all the cells, RBC, WBC, and platelets. And then, peripheral blood smear, which is such a simple investigation, which tells you about even the fragmented RBCs, which can indicate the hemolysis which is going on. Even the spherocytosis and reticulocytosis tells you that how immature RBC erythropoiesis is going on, how there is an inflammatory process going on. One message here only for the transaminases, as a physiological change, even normally during pregnancy, these liver enzymes are little elevated. But when it, almost doubles that of the non-pregnant level, then you consider this as abnormal. So that is what the major message we want to give. All of you know what is this proteinuria and how do you consider. Only thing is, significant proteinuria should be defined as 0.3 gram%, that is 300 mg/% in the 24-hour urinary sample. That is what the message is. All of you know the details of this, but then definitely I'm sorry. So now we come to the diagnosis of this patient, saying that yes, she is hypertensive, and if at all she has these alarming symptoms and signs, whether she's a case of non-severe or severe hypertension. So would you like to hospitalize this patient, and would you like to start her on antihypertensives? I think Dr. Shruti and Dr. Anita Srivastav, you can take up this question one by one.
Now that her BP, if on 2 occasions 4 hours apart, we do get this 140/90 figure.
Yeah.
I would definitely like her to be admitted, get her properly investigated, and start her on antihypertensives so that we can properly assess her progress. If the disease is not progressing, she is comfortable, the reports are coming normal, then we can discharge her with the oral medication.
Dr. Anita Srivastav, can we have your opinion? Do we have Dr. Anita here? Or maybe Dr. Dr. Swati Sharma? Yes, Dr. Swati.
Yes, ma'am.
Yeah.
Yes, ma'am. At this stage, at BP of 140/90, without any pre-monitory symptoms or adverse the blood profile, like the HDP profile, if she's not having all those problems, then at this stage, I would not like to admit her. I would like to counsel the patient, explain her the warning symptoms if she has any. She can monitor her BP at home with the home apparatus. We can call her with the BP recordings of morning, evening of at least 3 days. If they're
now I give you a, suppose for this patient, she doesn't have any alarming symptoms and signs, but when you investigate her, you find her liver enzymes are elevated significantly with 140/90 millimeter of mercury. Now, how do you classify this hypertension as?
Now she is a case of a preeclampsia with severe
hypertension. She is a case of preeclampsia, but she's a case of hypertensive disorders of pregnancy because she has proteinuria also. You are labeling her as, a preeclampsia. Okay.
So if she is having deranged, if she is having deranged liver function, now it becomes an indication because it is one of the sign of end organ damage which she is showing.
Can I say something, ma'am?
Yes, please.
Because there have been multiple studies and there was enough of evidence that if we start the antihypertensive at definite BP of 140/90, the complications are reduced. So nowadays with the latest 23 guideline and ISSHP 21, they say that you start antihypertensive once it crosses 140/90. So means this is what the latest news is.
Very well said, madam. And that I was coming to that point that yes, blood pressure of 140/90 millimeter of mercury, you cannot take it easily. I'm sure many of you have witnessed the patient conversing on 140/90. So it is not that it is not a mild hypertension. If she has additional features of severity, then we reclassify her as severe hypertension even with this blood pressure. Now coming to the guidelines, yes, previously NICE NHS in 2010 said that antihypertensives are warranted only when the blood pressure goes above 150/100 millimeter of mercury. But now the World Justice Organization, our own parent body, FOXI and ICOG, all of them together recommend that systolic blood pressure of 140 and diastolic of 90 millimeter of mercury warrants the use of antihypertensives. Okay, so this is how the management is, evidence-based. If at all she starts getting the alarming symptoms and signs, now we classify her as, that she is now prone for eclampsia. Now then the question of whether to go for the magnesium sulfate arises. But our patient is having only 140/90 millimeter of mercury, but she has got certain features of severity. So we just start her on antihypertensives. Okay, so we start her on antihypertensives for non-severe hypertension. Which antihypertensives you have as options and which one will you prefer? I think we have Dr. Priti Verma and we have Dr. Sushruta Srivastav. Dr. Priti?
Yes, ma'am.
Yes. So you can we have from you that whether for this non-severe hypertension 140/90, whether we have to start her antihypertensives? Yes. How do you choose? what are the options available for non-severe hypertension? Yes.
Ma'am, I choose tablet labetalol and start with 100 milligram BD dosing, 12-hourly dosing.
Yes.
Because labetalol is fast onset of action and having less side effect as compared to other antihypertensive drugs.
Yes. So what are the other antihypertensives which you can use in non-severe hypertension?
Ma'am,
what are the other antihypertensives?
Where, ma'am, labetalol is contraindicated.
You have alpha-methyl-dopa, you have tablet nifedipine retard. We're talking about, yes, nifedipine retard. Now, what are the conditions, what are the patients you will choose for labetalol and what are the patients you will choose for nifedipine retard? Can you, in other words, I would tell you, what are the contraindications to labetalol?
Contraindication for labetalol is as patient with asthma, heart failure, and liver disease.
And even severe bradycardia or heart blocks can also be the, because it leads to reduction in the pulse rate. And what are the contraindications for nifedipine? What are the problems with nifedipine? In other words, I'm sure those who are using nifedipine for a longer period.
Sudden hypotension.
I don't think so. Retard will cause sudden hypertension. Hypotension rather, but yes, you have severe headaches, because it leads to vasodilatation, severe headaches, which interferes with the understanding, the interpretation whether this headache is because of nifedipine or it is the alarming symptom. That is one. And secondly, the patient also keeps on getting more and more of edema. And thirdly, of course, the tachycardia, which is quite prohibitory. Now, why should we prefer labetalol? That is what the next question is. And Dr. Sushruta Srivastav, you can take up this question.
Thank you, ma'am. Ma'am, labetalol is now the first drug of choice in HDP, as we all know. And the reason behind is it is very quick in acting, quick in controlling the BP first. Then it also helps in proteinuria and systemic blood pressure को reduce करती है, मतलब peripheral resistance reduce करती है, तो it also helps in preventing IUGR because it maintains the
in other words, it maintains the uteroplacental blood flow.
So nowadays this is the drug of choice for.
And one more reason being, when the patient is already on labetalol, if at all she develops a severe hypertension, then you have injectable form.
Yes, it is in two injectable forms also.
Yes, so that is how it is. And one more advantage, if the people of my generation, they will say that when we have used methyl-dopa, then this drug is free of those side effects, as Dr. Anjali has very nicely discussed. So now coming to the next panelist, I would ask, why not alpha-methyl-dopa? Dr. Shruti, I would like to hear from you. Why not alpha-methyl-dopa?
Ma'am, the first and foremost, uska action is very delayed. It takes longer time to act, and we have to give
almost 24 hours, more than 24 hours. Yes.
Yes, and doses बहुत सारा देना पड़ता है. उसके बाद भी desired effect is not there, and moreover, it's centrally acting, selective नहीं है.
Yes, and of course you have many side effects of these drugs, though people of that generation say it was a wonder drug, but no, we have better drugs available. As you can see, the dosage schedule, as you said, 3 times 4 times a day, 500 milligram, and previously we used to have only one tablet of 250 milligram. Then the formulation changed to 500 milligram. That is one. But sudden severe postural hypotension, the lady starts getting up and she suddenly falls. So the sudden orthostatic hypotension, then of course the sedation which she used to have, even for postpartum period, you may have this sedation which will interfere with the breastfeeding as well. During pregnancy also, the patient used to lie down for hours together. And then of course, here also this drug has a side effect of headache and nausea, and also she looks a little confused as well. So all these were the side effects, as Dr. Anjali has also discussed, that thrombocytopenia, hemolysis, all this, whether it is because of this drug or whether it is a complication because of this progression of the disease, that was not interpreted properly, and that's the very reason alpha-methyl-dopa is not a drug of choice. Now we are managing this patient. what is your opinion, Dr. Shikha, about the strict bed rest and salt restriction? Dr. Monica has very nicely discussed this. So over to you. We're just revising because we want to be very clear in these messages.
So we would like to restrict the salt intake, of course, for the patient. And
what restriction you want to do? How you want to do?
We would ask her to restrict the salt by 4 grams per milligram per day. It should not be.
She will not understand how to restrict. Suppose you are talking to your patient, you can talk to me like that. What should I do? I'm asking you, madam, how should I restrict how much should how much salt should I consume?
No, it should be less than 1 table teaspoon, actually.
Yes, Shruti, do you want to add anybody? I think opinion of all the panelists on this point. Yes.
बाहर से नमक मत लेना, जितना खाने में डलता है उतना
Yes. So that is not restriction. You continue whatever is needed for your body. Yes. Only do not take additional salt. Okay, that is what the message.
मैडम टेबल सॉल्ट लेने को मना कर सकते हैं, जैसे उससे कह सकते हैं अचार और पापड़ ना खाए जहां तक हो सके.
Not to serve salt in your additional, in your
table
plate
salt
also.
nahi le.
Yes, so no salt, extra salt added, and of course no preparations which actually has huge quantity of salt. Okay, so routine salt is permitted, only extra salt is not permitted. That is what, and of course all of you will agree to me that a strict bed rest is not at all helpful. In fact, it is detrimental to the health because of the thromboembolic phenomenon. Okay, so friends, challenges are what makes life interesting, and overcoming them makes it meaningful. That is what is said by Joshua Marin. And this obstetrician who met with this patient, she actually thought, 140/90, nothing, no problem, go home. If at all you have any alarming symptoms, you come back. On 5th day, late night, around 11 p.m., the patient was brought to the hospital with severe headache, nausea, upper abdominal pain. She was not evaluated properly because she was not, hospitalized for 4 hours. Not the rising trends of blood pressure was not observed, and even baseline investigations were not sent because thinking that it is 140/90 is a mild hypertension. But now this is what has happened. Her blood pressure is 170/110. Her reflexes are breast. She has got epigastric tenderness. Now, how will you manage this patient? Once again, we go back to Dr. Nalini Mishra and Dr. Manisha Khare. Dr. Nalini, madam, you can take up this.
No, this is really worrisome. This is 170/110 and it's an emergency crisis. Rather, we should say this is a crisis situation.
Madam, I would like to interrupt you here. For the others, the house, how would you differentiate between the urgency and emergency? What is it that, differentiate from urgency from emergency?
Oh, emergency, you have to deal immediately.
Yes.
Yeah, and this is really urgency. There is a problem. There is a great problem. But no end organ damage, as you said, and we have some time in our hands. But in emergency, we don't have any time in our hands. Yes. So we have to go in an emergency
as soon as possible. Very well said, madam. So what are the drugs now available for, what are the options for this patient?
Yeah,
severe hypertension.
We have to admit her if we have HDU, ICU, wherever is the highest care zone. So we have to admit her there, and
madam, as an individual nursing, I would like to interrupt you here. Madam, we have individual nursing homes, but 170/110 with alarming symptoms, we are hospitalizing this patient.
Okay, so we hospitalize, and choice of drug you are asking is generally what we are using is first drug is the labetalol. Okay. So IV labetalol, although there are other drugs also like hydralazine or oral nifedipine like that, but generally we go for labetalol.
Okay.
So to begin with 10 milligram intravenously, then we take again BP in 10 minutes, and we target, of course, is
I think we
85.
start minimum from 20 milligram. We should start
10 or
that.
20 milligram, and then it can be repeated every 10 to 30 minutes. So हम लोग उसको ऐसे याद रखते हैं कि आई तो 10 आधे घंटे में 30 minutes में 30 means 20 to 40, then 60 minutes में 60 means 40 to 80. And then you continue 40 to 80 means you have to achieve that.
So
You
there
have
is
to
a
achieve the
definite
target,
regime we follow, what is Parkland Hospital regime, and also some more regime which is practically used. So Dr. Manisha, do you want to talk about this regime, how you practically give it in your practice?
If the patient is conscious, we can give her tablet nifedipine also orally, not sublingually.
No, to this I will not. Nifedipine, yes. I thought tablet labetalol. That is in fact very true. That is what we are talking about, that in addition to intravenous labetalol, you have oral nifedipine as the capsule, the orange color capsule. Yes.
And it can be repeated again after half an hour. And also we have to control her blood pressure as well as seizure prophylaxis. So we can give her injectable magnesium sulfate as well.
Yes.
Because she is in impending eclampsia according to me.
Yes. So you have to take care of both the aspects. The one is very severe hypertension that you have to control properly. And of course, you have to see that she doesn't convulse. But it's convulsion or eclampsia the only complication for hypertensive disorders? What are you worried about?
She is having upper abdominal pain also.
Yeah.
Planned into health.
With such a severe hypertension, Dr. Shruti, you want to take up this question?
Ma'am, there are deleterious complications we should see: end organ failure, cardiac issues, pulmonary edema, and hepatic rupture, renal failure. All these things. And if she convulses, uska mental, the CNS problems will start. She will convulse. If she convulses, encephalopathy mein she can land, and then there will be irreversible damage which will not be able to control.
So the message very well delivered here, that why are we worried so much about this severe hypertension? 170 by 110. So the capillaries, the vasculature is not adapted to this very high blood pressure, because now it is an acute rise in blood pressure, and you are worried about all these complications, including eclampsia. So our aim should be to reduce the blood pressure lower than this 110. Okay, first aim is to bring it down to less than 110. Now, how fast you should bring it down to whether you should get it normal, or whether it should get it by 140/90. What is your thought on this?
Ma'am, should I answer that?
Yes, yes.
Yeah, you should take at least 1 hour, means it should not be very fast.
Yes,
It should be in less than 1 hour, and the target diastolic should not be lower than 85. That is very important.
Yes. So according to the recommendations, that it is said that, the mean arterial pressure we have to reduce by not more than 15 to 25%. So if your patient has 170, 110, you take it down to 160, 100 first, then you take it down to 150, 96, 94, and slowly you try and control this blood pressure to 130, 85. That is what the aim of the therapy, and the reason all of you know very well that this lady's vasculature and the uteroplacental and fetoplacental circulation, it is adapted to that high blood pressure, and bringing down the blood pressure suddenly will do more harm than the benefit. Okay. So I think you have very well discussed this. Labetalol, how do you start it? 20 milligram intravenously initially. The onset of action is within 5 minutes, and the peak action is at 30 minutes. The duration is 4 hours. So when we are giving this initial dose of 20 milligram, you have to wait for 10 minutes. See that you're getting the desired lowering of the blood pressure. If you're not getting, you double the dosage, 40 milligram. Next 10 minutes, if you still don't get the desired effect, you double it to 80 milligram, and maximum of 300 milligram you can give. that is what, over 24 hours. We have already talked about the the contraindications for labetalol. Nifedipine, you have very well said, Dr. Manisha, that the onset of action is within 5 to 10 minutes and the peak action is at 30 minutes. So if you want to really give nifedipine, you do not have the ICU SDU facilities to give these drugs like hydralazine and intravenous labetalol, then I think oral capsule nifedipine 10 milligram is the drug of choice for this patient and these kinds of nursing homes. Hydralazine 5 milligram intravenously to be repeated after 10, every 30 minutes you can repeat it as 5 to 10 milligram with a maximum of 30 milligram you can repeat and this, but this has got alarm of having sudden hypotension. Only warning, only caution for drug nifedipine. I'm sure many of you of my generation has, 35 years back when we were the postgraduate students, definitely we have witnessed such kinds of mishap. The residents giving sublingual nifedipine and the patient just collapsing. We may sometimes have lost some of the patients. So a strict no to the sublingual nifedipine. That is what the warning from my side. Any other antihypertensives, if anybody knows and wants to talk about, is welcome.
It's given in books, but we have never nicardipine, we have never used it.
Okay, so I think the physicians, the cardiologists, they are using this molecule quite frequently. And this is also from the second generation hydropyridine derivative. This is a calcium channel blocker, almost 100 times more soluble than the nifedipine. And that is why the injectable form is also available. This is going to be a wonder drug, if I think, but because we do not have much experience and evidence as well, we are not using it in the hypertensive disorders of pregnancy. And also we have the esmolol, which is the ultra short acting cardioselective beta adrenergic blocking agents. This agent is also available for intravenous use. And although esmolol may be a useful therapeutic agent in obstetrics and obstetric anesthesia, the concerns about fetal safety has not been proven, and that's a very reason we are still not using it. Of course, persistent fetal bradycardia is one of the major drawback with this drug. So that is how now suppose we have this patient of severe hypertension and we have managed her maybe with either oral nifedipine or with intravenous labetalol. Now our patient is stabilized. We have just brought her down the blood pressure to optimum level of 150/90 or so. What are the investigations you want to send at this point of time, and how frequently you want to repeat it? I think you can have Dr. Sushruta, and we have one more panelist. I think we do not have Dr. Anita, right? So Sushruta and Dr. Swati, this is a question for you. What investigations you want to send at this point of time, and how frequently you want to repeat?
Ma'am, regarding the investigations, again, CBC, complete blood picture count, liver function test, renal function test, and PT-INR is also to be taken in care. And again, the fetal Doppler.
Okay.
And fetal Doppler to look.
Yeah, you have to monitor the mother. As
we have to monitor both mother and baby.
Okay. So you do her investigations initially. You find her liver enzymes are elevated, and you find that her renal, serum creatinine you take for pregnancy 0.8 milligram. Okay, for her it is almost 1.2 milligram. How frequently you want to repeat this?
Now we'll start the treatment and we'll check it from daily basis.
We are not talking about the treatment. We have this impaired liver and renal function test. So how frequently you want to repeat the investigation? That is
after 24 hours, we have to repeat it to check it whether it is deteriorating or is it improving.
Perfect. That is what the message we want to give, that if at all the investigations are normal or within normal limits, we may just repeat it after 1 week if everything is fine and the mother is stable. If at all there are, certain disturbances in her control of blood pressure, you may just repeat it every 3rd day. But if you have severe impairment in the renal and liver functions, then you have to repeat it every 24 hours. Now, you have taken this patient, very carefully. You are trying to go ahead with this pregnancy. You find the blood pressure is good, well maintained, and the parameters are also okay. So is there any point of time where you want to take her beyond 34 weeks at least? So how do you prepare this patient? That let me discuss about this first. What all things, Dr. Swati, should we give for this fetus to prepare?
And we can put the patient on, we can give the dose for the pulmonary maturity, that is betnesol and dexona, we can give, so that we can assure the fetal pulmonary maturity.
Both or single?
Just one, any of the two. Any of the two we can give. 12 mg beta methazone. We can repeat with the second dose after 12 hours, and dexona again 6 mg 6 hourly, 4 doses. This is how we are going to look for the pulmonary maturity, assure her pulmonary maturity of the fetus.
What is your opinion? Which one is better, betamethasone or dexamethasone?
Dexamethasone is better, especially.
Yeah, so actually betamethasone is the drug of choice for this, but the betamethasone which is available in Western countries, the salt propionate is not available in India, and so we do not have the effective betamethasone here. So for Indian population, dexamethasone, even the government of India, I think you must have, all of you must have used also in the government hospitals, they have the dexona vial, 6 milligrams 6 hourly, that is 4 doses over 24. So what FOXI and IAP, they have come up with a joint statement. They are saying that 24 milligram over 24 hours, and either of betamethasone or dexamethasone should be okay to go ahead with the lung maturity, for the lung maturity. Okay, so you have given this, and what else you want to give for this fetus, if at all she lands up into some preterm intervention? In addition to steroids, anything else you want to give?
Yes, ma'am.
Anybody can take up this question. Yes, Dr. Shikha, yes.
So we can give Maxel for the neuroprotection of the child.
Yes, how do you give it? How much do you give?
We give 4 gram IV bolus, and then we will repeat 1 gram per hourly for 24 hours or after delivery, whatever occurs first.
We repeat means you give bolus every hourly, or you give as an infusion?
Infusion. I would like to give as an infusion.
Okay, correct. So that is, if at all, we will be having the discussion further. This is like the intravenous regime of magnesium sulfate, what we call it as Zuspans regime. So this is the same what we are using for the neuroprotection of the baby. And this is 4 gram initially as loading dose and 1 gram per hour. So how do you prepare this infusion for 1 gram per hour? Can anybody tell me? Because we have been using it very regularly in day-to-day practice. So can you just discuss? Yes, Dr. Preeti Verma and Dr. Shruti, yes.
Madam, 9 grams maximum dissolved in 500 ml saline. और pediatric drip set से अपन 1 microdrop per second करके देंगे 1 घंटे में. So slightly more than 1 gram will be.
Okay. So I tell you,
infusion pump होने से तो कोई problem नहीं है. Otherwise, this we can do.
Yes. So those who do not have ICU HDF, yes, anybody wants to add something here?
We have an infusion syringe of 50 ml. Then we dissolve 10 ml of magnesium sulfate with 40 ml.
How many grams? How many grams?
Ma'am,
5 grams, yes.
5 grams of magnesium sulfate in 50 ml of normal saline, ma'am. Making total 50 ml of solution.
Then
and we start infusion with 10 ml per hour. So we are giving 1 gram in 1 hour.
Okay. Okay. So
I want to say something.
Yes, please.
The later regime seems to be more this thing, because we should not give more fluid.
Perfect. That is what the message.
Because you see, unless there is some ongoing loss of fluid, vomiting, diarrhea, or hemorrhage, then we should restrict to 80. It shouldn't be more than 80, because of the reasons known to us, because of the pathophysiology of preeclampsia. So it's always better to give it in a lesser.
Perfect. That is what I was coming to the point, that yes, previously we had very simple measures, but for eclampsia, when we did not have any option, 4 gram loading dose and 1 gram per hour, that you just add 5 ampoules of the magnesium sulfate in 500 ml and give 100 ml over 1 hour. So that is what a simpler measure. But as you have rightly pointed out, that we have to go ahead with fluid restriction, because whatever amount of fluid you're giving, it will go to the interstitial spaces, and that will further add to her risk as far as edema, may it be pulmonary edema and pulmonary congestion is concerned. And that is why we have recently a newer preparation by the I won't say the pharma name, but we do have the concentrated infusions of magnesium sulfate coming up nowadays, and maybe let us see how we can use it in future. Now we have managed this patient very well. Severe hypertension and even the monetary symptoms we have dealt with. Are there any situation in addition to this that warrants termination of this pregnancy prior to 34 weeks?
Abrupt shock symptoms.
Yes. What else?
Fetal Doppler, signs of fetal Doppler.
So you will have certain maternal indications and certain fetal indications.
Feature of renal failure and fetal distress. These are the indications that indicate immediate delivery.
Yes, you're right. So for maternal complications like eclampsia, abruptio placentae, HELP, acute renal failure, or maybe some intracranial complications, and fetal, there may be some problems with the Doppler studies. Either you may have absent end-diastolic flow or reversal of end-diastolic flow, or maybe even the fetal death, intrauterine fetal death. These are the indications for interventions prior to. So we have discussed this Maxwell very well just now. Which regime do you prefer? One more question before that: whether what is the difference between the prophylactic and therapeutic magnesium sulfate? I think we go back to the round once again to Dr. Manisha Khare.
Prophylactic, we give only loading dose.
Is it okay?
We give 4 grams. 1 ampule has 1 gram of 50% magnesium sulfate. So give 4 ampules to be dissolved with 12 ml of distilled water, and it has to be given directly IV.
Okay. I think we will have all panelists' opinion here. Madam Nalini Mishra, you can talk on this.
Prophylactic we give in preeclampsia patient with severe symptoms, and therapeutic magnesium sulfate we give in patient of eclampsia.
Next, Nalini Mishra, Madam. Yeah.
So that's it. If she is having convulsions, eclampsia, then naturally the therapeutic doses is there, and prophylactic dose we can, if the patient continues and is well settled, otherwise we can consider stopping it after 24 hours.
Okay, so I think we interfere here with the discussion. First and foremost, you have these 2 regimes, that is sure, which are commonly used, Zuspans and Pritchard-Maxwell regime. But the basic difference, as somebody has defined it, prophylactic, yes, you want to avoid convulsions. The patient is only prone for convulsions. Therapeutic is you want to treat the eclampsia. Okay, that till this I agree perfectly. But what does the evidence is, whether it is prophylactic or whether it is therapeutic, the entire dose and the regime, it has to be the same. Yes. So there is no question whether you should give only loading dose or the maintenance dose, and so whether it's prophylactic or therapeutic, the regime to be followed is whatever regime you are following, but the dosage and the regime has to be a complete regime. Okay. Now,
but madam, the only thing is, can I say something?
Yes, madam.
Yeah, the regime is same, but what happens if she is having eclampsia, then they say the delivery or the last convulsion, whatever is
Yes,
later,
yes,
no?
yes. So you give it only for 24 hours.
Yeah, and in the latest guideline, they say you can consider stopping it if she is progressing well and is well settled. Then you can consider stopping it. That's the
But
only
that
difference.
you have to actually see when you are monitoring various parameters, that her reflexes are not brisk and she's having good, yeah. So all those parameters you have to really monitor very stringently. So this is what a neonatal outcome, we have already discussed this, and now this patient which we have been discussing, she is undergoing all the investigations. But this patient, I will take you back to the history, that this patient, suddenly started getting severe headache also, which she was having the day she came to you, 170, 110. But when you examine, she started getting pain in abdomen. So when you examine, you find that the uterus is tense and tender, and the fetal parts are not well felt. Fetal heart is 110 to 120, and she's got a little bleeding. So when you do her internal examination, you find that because you are sure bound ultrasound, the placenta is not low lying. You do her internal examination, ossis 2 fingers loose, station is high up. So what is the diagnosis at this point of time now? What has she landed up into, and how will you investigate and manage her?
Now she is a case of abruptio placentae. And we would like to do her coagulation profile as early as possible.
We have to deliver the baby as soon as possible.
Yeah, but before that, she has to investigate that, Dr. Shruti.
Yes.
She's right. We have to send the investigations, yes. At the same time, everything is simultaneously. Okay. Who's going to discuss the management? She has sent the laboratory investigation, especially the coagulation profile. Okay. Dr. Shruti, you want to take up this question?
If she has the favorable bishops, we would like to further proceed with the...
You what bishop she has. We have provided you os is 2 finger loose and station is high up. Is it favorable?
Here the fetal heart is also going down, so it's better to go for an emergency LSCS in this case.
That is what. Now you tell me, Dr. Sushruta, whether you would like to arrange for, her investigations meanwhile comes to you, the platelets 50,000 only, bleeding time, clotting time, okay, but fibrinogen 150 and FTP is present. What is your diagnosis now? She's landing up into DIC. Yes, perfect. So whether you would like to arrange for blood and blood products first, or you would like to go for cesarean section first?
We have to arrange the blood and blood products, and by that time we can proceed for cesarean section.
Yes, yes.
And by the meantime, we are ending up. We will start transfusing the blood products to her.
Yes. So it is not that which one you will do. Both are, you have to act simultaneously. In addition to all this, you have to arrange for the emergency cesarean section. You have to arrange for the blood and blood products and starts acting fast, because there's something what is called as abruptio delivery interval also. So when you have more and more time lapse, the DIC worsens with time, and that's a very reason even for the management of abruptio and DIC, you need to deliver fast. And here you have fetal distress, so naturally you have to deliver the baby at the earliest. Now for this patient particularly, you have the findings, platelet 50,000, which anesthesia you want to choose, and what are the risks with other type of anesthesia. Can we have the answers from now the next panelist, Dr. Swati, and we can have Dr. Shikha. Yes.
But because the platelet count is nearly 50,000, we can still go for the spinal anesthesia.
Because the BTCT is normal.
Yes, ma'am. BTCT
Right.
normal.
Yes. Okay.
So we can go for the spinal.
Should we go for spinal or should we go for epidural?
And we'll go for
a regional anesthesia that is preferred, but it should be preferably a epidural anesthesia. Okay.
It can be delayed.
Yeah. But then if not possible, for emergency, you can go for spinal anesthesia as well. So if the platelet count is less than 50,000, definitely If the patient is having convulsions, she's in status eclampticus, she's not, I mean, it's not, you are not able to give anesthesia, then only we should think of the general anesthesia. Now, a patient has got 50,000 platelet count, okay, fibrinogen is 150, and she's got FTP present. So what is her score, DIC score, and whether she is in mild DIC or severe DIC, how overt or, non-overt DIC? Yes, Madam Nalini Mishra, Manisha, Dr. Manisha Kare. Dr. Manisha, do we have Dr. Manisha here? Yes, please unmute. Please unmute. That's the reason I was wondering why I can't hear you. Please
Manisha,
unmute.
you are muted.
No, yeah.
So more than 1 lakh is normal. 50 to 1 lakh is mild DIC. Less than 50,000 is she is in. Platelet count is low.
Yes. So you have very rightly said, but you have certain score, DIC score, where you have the platelet count, the prothrombin time, serum fibrinogen, and FTP, the D dimer. All these considered together as the DIC score. And if it is less than 5, then it is a non-overt DIC. If it is more than 5, then it is an overt DIC. Of course, there is no change in the management per se, but you have to be little aggressive on the overt DIC. And yes, because you have to sell through this operative procedure also. So keeping blood and blood products ready, and you have to take a decision for emergency cesarean section. This is one more complication we have been talking about. She's got persistent headache right from the beginning, and suddenly you feel that why, in spite of all the well-controlled blood pressure and all, why she's getting this. So when you investigate her, do her MRI, you find that this is the picture. This is the high signal intensity bilaterally, that is parieto-occipital white matter, consistently with the vasogenic edema, that is what is called as the PRESS syndrome, posterior reversible encephalopathy syndrome. And the good news or good point about this is self-limited. If at all you diagnose properly, and if you rule out the other complications, then of course you have to just support her properly and go ahead with the management with the help of the neurophysician. So that is all about this. I think usually it reverts back, or it is self-restricted, and she regains her vision, everything after 7 days, within 7 days, I would like to say. And with this, I would just like to say that the crisis is integral to human life. Those who timely and appropriately contract it will survive and succeed. So friends, not to get panic, just have adequate knowledge, implement it, do your actions timely and appropriately, and you will sail through. I will not like to go through the take-home messages. All of you are wise enough, and I'm so happy for wonderful inputs from all the panelists. And I would like to thank the organizers, the Bhopal Society, especially Dr. Monica Singh and Dr. Anil in particular. And I take this opportunity to humbly seek your blessings for my candidature as Foxy Vice President from West Zone. Friends, we have 2 posts for West Zone. I request one of the 2 precious votes from you. Thank you so much once again, and over to you.
Madam, we have voted yesterday.
1 minute. Can I speak just 1 minute?
Yes.
Ma'am, I'm the example of this, what we've been discussing for the last 2 hours. 23 years back, during my DNB, I landed up into eclampsia, 200 by 110 BP. And now, since then, every day I've been correlating and being so thankful for the medicines now available. We had no labetalol. I was on to methyl dopa, lots of it. There was no betnazole dexona given. And my daughter was 1.6 kg when she was born. I was swollen. And मेरा residency था चोइथराम में, इसलिए I could be managed in a tertiary center, and I am alive and sitting here. And my daughter has completed her MBBS. Now she is into internship. So this is what this condition can do to you.
Yes. But thanks to all the medicine and thanks to the, our mentors and guides and the senior practitioners who have been saving our lives.
Yes.
So,
Shruti, you're a born fighter. You're a born fighter. She survived a very bad car accident also.
Oh.
She and her husband. So, Shruti, I think you are the chosen one, to survive. Madam, there is a question. There's a question in the chat box that Manjulika Bajpayee has asked. Please explain about Nicardia retard use or not. Duvadelon retard should be used or not in premature pains due to hypertension.
Yes. So first and foremost, Nicardia, she has said, which is the retard formulation of nifedipine. Okay, so when I was discussing initially the non-severe hypertension, I was talking about 3 options. First and foremost, the drug of choice, labetalol. Second, the alpha method, just to name it as a list. Second, Nicardia retard or nifedipine retard. And third comes alpha methyl because that is not available nowadays and we are not happy with it. So for now remains labetalol and Nicardia retard. So Nicardia retard is definitely a drug to be used when the patient has non-severe hypertension. That means she has no other complication. And in fact, we have discussed, if at all you have missed it, I repeat it, how to choose between labetalol and nifedipine. So when you have a patient who has got asthma, congestive cardiac failure, or heart blocks, then you have to choose the nifedipine, which is a long-acting, that is Nicardia retard. Or on the other side, if you have a patient who's got lots of edema, maybe tachycardia, maybe she always gets a headache, then this is a patient for whom you should choose labetalol oral tablet. So that is how. So
she's asking the patient is in premature pains.
No, that is for Nicardia retard for okay.
Oh,
so this is about hypertension. I thought it is about hypertension. So definitely Nicardia retard, not Nicardia retard. In fact, it is a nifedipine which we have been using regularly, and it is said nowadays that calcium channel blockers are the most effective and most, I would say, safest tocolytics to be used. And nowadays, for many people, nifedipine is supposed to be the safest tocolytics. That is what, definitely, if you have a patient who is going into preterm labor pains, and if she doesn't have established preterm labor, definitely you can go for tocolysis with nifedipine, that is Nicardia retard also. Yes.
Thank you, madam.
Thank you so much.
So, madam, thank you for that wonderful moderation of the panel. Only a very seasoned clinician like you can manage so many top class panelists and still give a message to everyone. And I was a very keen listener because I'm not dealing with all this anymore. So I'm in a very inquisitive mode over here.
Yeah,
So
but you two delivered your talk excellent. In fact, though the presentation was by Dr. Rekha Vadwani, I was, very curious how you deliver it, because you are an infertilologist, IVF specialist mainly, but you did wonders to that presentation. And
Thank you, ma'am. Thank you.
Thank you.
So, ma'am, this has been such a great honor for us that AMOGS could join with BOGS. In fact, when we were discussing everything in a previous meeting to about 1 week or 10 days back, and I invited everybody, I was wondering how to coordinate because it seemed a difficult task. But, people in my society in Bhopal are so cooperative that everybody is ready to help at any time, middle of the night also. So, ma'am, we are really honored and we wish you all the best. Yesterday, I have voted for you already. So,
thank you, Dr. Monica. If I share with all of you, basically, I'm not a politician. I'm a hardcore obstetrician practicing for last 31 years now. And I'm a very focused person. I do update myself as far as the knowledge, implementation, everything is concerned. And I know all of these, people sitting here, Anjali Kanere, Madam, Dr. Manisha Khare, all your society members, I would say majority of them, I know them very well. and they are wonderful people. I know how much they love me also. And this is not just for the sake of elections and votings. I am a genuine person and I want to be like this only. Elections, posts and all these things keep coming and going. I don't care for that. But yes, thank you so much for all your emotions, all your love, and I value all of you. Thank you so much.
Thank you so much, ma'am.
Thank you, everybody. It was a wonderful webinar.
Thank you, my dear. Thank you
Anjali
so
Didi,
much.
your talk was very beneficial to all of us, and it was a very nice postscript to my talk, Dr. Rekha's talk. And I really miss Dr. Rekha Wadhwani today, but because of her, I could learn such a lot about PE screening because I was reading about it whole night yesterday. So I'm very happy it gave me a break from my routine subjects. Thank you so much, ma'am. And please keep us and Bhopal in your blessings always.
Yes. Yeah. My dear, I'm not such a grand person. I'm just one of you. Friend for all of you. And definitely, as I have promised, in fact, I say what I mean it and I mean what I say. You all are in my heart and I'm going to take you along, definitely. Thank you so much, my dear.
Thank you so much.
Shruti has worked with me, so she has the experience. Definitely, anybody who is eager to work is welcome. Thank you so much.
We all are with you, ma'am. We all are with you.
We all
Thank
are
you
with
so
you.
much.
Thank you so much. Thank you so much, Anjali Didi, Manisha Didi, Shikha, Shruti, Nalini ma'am.
Thank you, everyone.
Dr. Rachana, thank you so much, my dear. Thank you so much for
Rachana ma'am.
joining us.
Thank you, Rachana ma'am. Thank you, Sahiti, and thank you, Shield Pharma, for this Zoom platform.
Thank you, ma'am.
And
thank you so much.